Morning, everyone. Anybody has a camera? I would love to see your face. That I'm not much interested in just talking to a bunch of little avatars or names up on a screen. So, good morning and welcome. Today is for some of you, the first day of your critical care course. For some of you, I apologize. It is the painful second week of Zoom. We will try to make it a little less painful. Now, some of you might be thinking, painful? How can this be painful when I'm sitting at home with my cup of coffee? I threw a load of laundry in before I started. Oh, you wait, you just wait. Your head at the end of the day will be a little bit volume overloaded. So I try and put up a poll every day to, I don't know, just to make it interesting. So I'm not going to answer that question. We're about 50-50 split on that question. So I'm not going to answer that question because it is a question on one of your assignments. And if you listen well today, you will have the answer to that. So I'm going to stop sharing that. Okay, so good morning. As I said, my name is Sue, and we are a lot smaller class than we were last week. So I like the intimacy, not in a creepy way, but normally I have a picture of Las Vegas behind me. This morning, my computer didn't want to behave, so my picture of Las Vegas is missing. So you can see that Ima is hanging out in San Francisco. I usually hang out in Vegas. So if you want to blur your background, maybe you have some sexy guy or girl in the background that you don't want any of us to see, then you can go, there's a little tiny up arrow beside the video button, and you can blur your background. Mandy, I don't want you to blur your background because that little guy is adorable. Dale usually has a dog and a cat that will join us periodically. Do you just have one dog, Dale? I mean, not that that's enough. Okay, because somebody else last week, it might have been Annalise, had a couple of dogs and a cat, and they were getting pretty bored at the end of the day. They're like, okay, finish. But if you click the little up arrow beside your video, you can go in and it says blur my background or choose a virtual background. So that's your choice. You can also put filters on. So there's some weird filters, like I can put happy faces all around me. Where's the one? Yeah, I like this one. So, yeah. Hey, dude. I mean, I will not do that. It's very distracting when you're looking at me as your instructor. But yeah, so whenever you get bored, I can usually tell when people are getting bored because they start putting filters on or their camera has died. I know that some of you do not have a camera, but I would like as many people as possible to have their camera on. And the only reason why is I like to see your face. If I'm boring you, then I know it's time for a break. Um, this is a judgment-free zone, and that's why I like to put a picture of Las Vegas up. So what happens here stays here. So if you think, oh my God, I've always wanted to know this, but I don't want to ask because I'll look stupid. That doesn't happen in this class. This is a class where you can ask anything appropriate about work, about cardiac nursing. I don't want you to be intimidated. I want you to get to know your colleagues, because when we start on, I think it's Thursday maybe, we will start course 2. And in course 2, you will work together as groups to do a case study presentation. So some of you are what I call New Brunswick critical care nursing students. And some of you are called unregistered students. And I know that doesn't sound nice, unregistered. That just means you're not enrolled in the course, but I have enrolled you to do your cardiovascular education. So a lot of what you will take, Erica in particular, in this course, you would have done some of it previously in your orientation. So Erica is the only one that has permission to sleep. If you know me, I'm pretty chill. I don't get too stressed out. Now, do you guys think I'm going to be here yapping until 4 o'clock every day? My God, slit my throat, slit your throats. You will not be able to deal with that. So I try and focus on the most important parts in the morning, because you leave, you have lunch, you come back, and nobody's really into it, even me. So I try and finish by the latest 2:30. Maybe there's one day that we go to 3 o'clock, but I try not to go the whole day because that's pretty painful. I'm also going to try and give you a break about every hour so that you're getting up and moving. And for those of you that have hung out with me in the past, what are you going to do at the end of the day before you go pick up kids, before you do any housework kind of stuff? What are you going to do at the end of the day? Yeah, you're going to go for a walk. And so how did I know that Sarah said that? Well, we have a chat box, and I keep my chat box open all of the time. That is likely the easiest way for you guys to communicate, except I love to hear your voices. So we're going to start this morning with a dumb little exercise. So you're going to tell us who you are, and if you were a Smartie, you know, those great things that we just over ingested the other night, what color would you be? So my name is Sue, and I would be a red Smartie, because there used to be a little saying that you eat the red ones last. So that means that I get to live longest and enjoy the most life. That's how I think of it. And not because I'm picking on her, but she's in my box on my screen up in the left-hand corner. Sarah Sipkema, tell us who you are, where you work, and what color Smartie you would be.
I felt like I was going to get picked on first, so I'm ready. So my name's Sarah. I work on 5B North in the Heart Center, cardiac surgery. I'm the resource nurse there. And if I was a color Smartie, I mean, I don't have a cool thought out one. I'd probably just be purple because I like purple.
So what's wrong with that? Most people give me the color they like. Awesome. Thank you for sharing. Sarah, what about you? Tell us who you are, where you're from, and what color Smartie.
My name's Sarah. I'm from Woodstock, New Brunswick, and I work at the Upper Valley Hospital here in the ER. And I feel like I would maybe be a blue Smartie. I just like the color blue. I don't have a reason as well.
That works for me. I like that. Thank you. Michael, how about you? And Michael, you know already I love boys. I'm going to pick on yous. I have three to pick from. No, I don't. I have four to pick from. Sorry. Michael,
Hi,
tell us.
hello. My name
Oh,
is Michael. Okay, my name is Michael. I'm working in the Moncton Hospital in emergency department. So if I choose my Smartie, I will pick sky blue because that's my favorite color.
I love it. Perfect. See, it doesn't have to be a real scholarly thought. It just needs to be what works for you. Awesome. Thank you. John, all the way up at the top of our province. What about you? Where are you from?
Okay, I work in intensive care in Edmundston. Um, I'm originally from the United States, so I'm vaguely familiar with Smarties. So we don't really have them where I'm from, but I think there's a green one, so I would go with that because it kind of resembles a vegetable, right? Yeah, it might be healthy. Yeah.
You get an A for critical thinking. I like, you must be so pleased to be in Canada, especially this week.
Yes, yeah. It's yeah. I'm happy to be here. My wife's from Edmundston, so that's why I'm here and our little daughter who you might hear in the background, yeah.
Awesome, awesome. She's allowed to come visit, and I promise I will try and fix my potty mouth so that your children in the background are not kind of, traumatized by the fat lady on the screen. Yeah. Awesome. Thank you for sharing. Samantha, so we do have another Sam. She is not here today. Her grandmother passed away on the weekend. So I will call you Sam number one, or do you like to be called Samantha?
I prefer Samantha.
Perfect.
Hello, everybody. I'm Samantha. I work at the Moncton City Hospital in the ER with Michael and Amy.
Cool.
I would choose probably the blue Smartie because blue is my favorite color.
Hey, I like that. Thank you. Thank you for sharing. Mandy, how about you?
I'm from Moncton, but I moved to St. John earlier this year. I actually took the critical care course in 2019 or 2020 with you. I've been working in neuro ICU, but I'm going to start in the cath lab.
So big learning curve. But the really nice thing is now we have a neuro specialist in our cath lab because we are pretty focused on cardiac and forget that the rest of the body exists. So when we're trying to do a cath on a patient who is unresponsive after TNK, maybe you can encourage them to get a CT scan before we. Sorry, I digress, but
Okay, the neurosurgeons want nothing to do with cardiac either, so.
it's so true, isn't it? Yeah. Awesome. Thank you for sharing. Ima, tell us about you.
Hi, my name is Immaculate Gomez. I'm from 5B North Cardiac Surgery. And I think I will go with blue color because that's my favorite colors for Smarties.
I love it. Yep, that works for me. Awesome. Jiva, how about you?
Morning, everyone. My name is Jiva Marlin Jacob. I was an IEN. Just I passed my NCLEX, so I will be starting with 5A North. 5A North in the critical care.
That is really quite an accomplishment. And I feel bad for you that you've just finished studying for your NCLEX and then you get dumped into this.
It's okay. My favorite color is purple. So I got it.
Purple. I totally get that.
Thank
Awesome.
you.
Perfect. Thanks for sharing. Erica, how about you? Oh, I'm not hearing you. I can see you talking, but I can't hear you well. No? Oh, Larissa, that's okay, Larissa. Try your best to find a spot where Wi-Fi works. And I'm gonna unmute you, Erica, maybe. There, you're on. I still can't hear you. No. If you go, there's oh, I should be able to hear you now, so I can hear movement in the background. A little bit.
Can you hear me?
A little bit.
Great. My name's Erica. I work at the 5A North ICU. And I probably blue.
Blue? Okay. Yeah, I think if you go down to audio, down using in your left-hand corner, and click on the little arrow beside it, test your microphone. I think it just needs to be adjusted. Awesome. Thank you for sharing. Ray, how about you? Tell us. And so is your name Ray or is it your full name? You tell me.
Hi, good morning, everyone.
Morning.
My name is Ray. I am presently working in the Moncton Hospital in 3400, which is a CCU step down. I choose color black other than, I mean, it's because I love black really. And I do believe that it's really easy to match everything with black.
So true. Our uniforms are so easy.
Yeah.
Awesome. I'm going to tell you what usually colors mean, but when someone likes a black color, they are a mysterious kind of guy or girl. They love Halloween, but they're the type of person that I'm not going to share very much about myself. You're going to have to figure it out. Does that describe you, right?
I don't know actually. I don't know how my friends defines me. Yeah.
Well, you have friends, so that's all that counts. Awesome. Thank you for sharing.
Thank you.
Mariah, and am I saying your name right? Probably not. I'm bad with names.
Is that for me?
That's for you. I'm obviously saying your name wrong. How
okay.
do
My name is Mari.
Mari, thank you.
Okay. And I work at the DEC ICU. And I would pick the blue Smartie as well because I really like blue.
Hey, awesome. See, we're blue, we're black, we got a little purple thrown in. Those are all, nobody's been yellow yet. Or maybe I'm stealing someone's thunder. Oops. Okay, awesome. Thank you for sharing. Amy, how about you?
Hi, so first I want to say sorry, I have two 11-week-old puppies.
Oh
So
my
you might hear some barking. And you did steal my thunder. Yellow is my favorite color, so we're gonna go with the yellow Smartie.
She's Susie Sunshine. She's like, her glass is pretty much always half full, not half empty. Does that describe you?
Yes.
Okay.
And I work at the Moncton City ER with Samantha and Michael.
Awesome. Okay, cool. Thank you for sharing. Dale, how about you?
Hi,
Morning.
I work right now at the deck on the CCU and the step down unit, but I'm in the process of moving to St. John. I get a full-time job on 5A North. So I would pick a pink Smartie.
Ah, and so does pink work for you? Is that your color?
Yeah,
Does it make you happy?
it does.
So people who like pink and purple like nice things around them because it makes them feel good. And whether that is a nice looking boy or girl, a nice looking picture in the background, like
Mrs. Mason.
or your dude could be two-legged or four-legged. Yeah, quite beautiful. Thank you for sharing him. Delia, how about you? Tell us about you. And am I pronouncing your name correctly?
Oh, just a sec.
I can hear you.
Sorry, my computer is slow.
That's all right. We can hear you. That's okay.
Just waiting for the video.
Sometimes the bandwidth is, look, she's hanging out in San Francisco too.
My name is Delia. Back in the Philippines, we don't pronounce as A as A, but it's A. So back there, Dahlia. But when I met older people here, it's Dahlia because it's a flower. So when I introduce myself to the patients, I will say Dahlia because they always call me Delilah. So I will say Dahlia like the flower. So I used to work in Gen Surge, and then I applied for a full-time position at the 5A North. So I'm on training right now. So I don't have an experience with cardiac whatsoever. So it's painful for me. But I'm trying my best to learn.
You're doing just fine.
I like the pink Smartie. I love to shop. When I'm stressed out with work, I'll just go shopping. So sometimes every day if there's a parcel, my husband says, "What's going on here?"
It's a coping mechanism. I love it. Well, awesome. Thank you for sharing. There's a girl that works on 5B. Her name is Mary, and she is also from the Philippines, and she also loves to shop. So I don't know if you know her, but I will connect the two of you. Yeah, she said she doesn't have any men in her life because she doesn't want them to rant at her about how much money she spends shopping. Too funny.
Oh, I'm a sucker for overtime, so I use my money from overtime to shop.
I love it. And don't you love the fact that we as nurses have that ability? Like, hey, I'm planning a trip. I'm doing this and doing that. I'm gonna work. Oh, I need 12 hours of overtime. I need, I need to get 16 hours of overtime. And it really isn't a hard thing to find, is it?
Yeah, I have a coworker. I don't know if you know her, Patty Reed. She
Yeah.
likes to pick up overtime because she goes on a trip every year, multiple times.
I totally get that. I just work two jobs. Awesome. Thank you for sharing. Jillian, how about you? Way up again at the top of our province. Well, not quite at the top. Close to John, but not quite.
My name is Jillian. I just started working at the ICU at the Campbellton Regional. And if I was to pick a Smarties color, I'd pick blue because it's also my favorite color.
Ooh, we have a lot of blues. Blue people usually like the outdoors. They like anything that makes them feel good. So blues and greens kind of go together. Awesome. Thank you for sharing. Adam, how about you?
Good morning. I'm Adam. I work in the Charlotte County Emerge, and I would pick orange because I like the fall.
Ah, I like that. I like that. So, for those of you way up here in Edmundston and Campbellton, Charlotte County is in St. Stephen, just before it borders with the state of Maine. So, yeah, so we're spread out all over the province, which is awesome. Thank you for sharing. Nav, how about you? Tell us about you. I don't know if you're unable to mute yourself. So down in the corner, if you click on the mute or there you go.
Hi, I'm sorry. Hi, sorry if my camera is not working.
No worries.
This is Nav. I'm working at 5A North Step Down CCU. So my color is red and yellow. There's no
Oh,
reason behind that, but I love red and yellow. Yeah.
I love it.
Yeah.
You're one of my first combo people. I have to look up in my psychology textbooks what that actually means.
I believe it's a color of fire.
Ooh.
I
Aha.
like it.
So does that describe your personality?
I believe no.
No. You're a mellow, chill girl.
Yeah.
Awesome. Well, thank you for sharing.
Yeah, thank you.
And I'm not sure how I say your name. Shania, you tell me.
Hello, can you hear
Hi.
me? I don't know if my camera's working, but I'm turning it on.
Okay.
It's Shania, like the singer Shania Twain.
Perfect.
I work in the deck in float team, but my home unit is step down in CCU.
Excellent.
I don't know what a Smartie is. Is it a candy?
It is. I was going to say, I'll try and find you a box, but my husband and I have hosed them all into us, so there is none left.
I don't know what color are there in, but I'll choose yellow in any candy because it's lemon flavored.
Awesome. Yeah, it's kind of like Skittles, but better.
Okay.
Awesome. Thank you for sharing. And last but not least, Larissa, how about you? Tell us about you.
Hi, I worked in ortho and now I'm going to be working in the cardiac cath lab. And my favorite color is yellow, so I'd pick yellow.
Awesome. I love yellow. Now, there's a message in my text box I just want to. Yeah, it's funny. It's funny you should say that, Shania, because I got a message from Andrea, your manager, on Friday to say that you and Melanie won't be in course 1 or course 2. And I sent her a message back and said, well, sorry, but they both successfully completed course 1. So I'm strongly encouraging you to check your paycheck this week to make sure that you got paid for last week. And second of all, I didn't realize that you guys were joining us until Friday. So that's all right. I'm going to put today's presentation in the chat box. So just give me a second and I will find our presentation, copy it here. There you go. So that is the presentation that we are doing today. Yeah, so didn't know if Melanie was coming or not. So that's all right. I told her she could send whoever she wants, whenever she wants. That's the nice thing about being on Zoom. So you're all wondering, what is she going to expect from me? This is my first day of class, and some of you are like, I'm just doing this for my orientation for my job, and what am I getting sucked into doing? So Dale and Dahlia and the ladies from the cath lab, don't sweat, I will put you all in one group kind of thing, and we can talk about what I'm going to force you to do. The rest of you, I am going to force you to do stuff. So this is the end of course 1. So last week, everybody here has successfully completed basic cardiac monitor interpretation. You might have done it last week, last year, or a few years ago. Completed, that's done. The second part of course 1 is what we're going to do today and tomorrow, and that is 12 lead ECG. And so 12 lead ECG, although this is a basic novice course, I still learn something every day about a 12 lead ECG, and I am a very old lady. So there's so much to learn. I think once we stop learning, it's either time to retire or go find a new job, because nursing never stops learning. There's something new. And I think we all probably work with that one, maybe 2 persons who you think, oh, sister, it is time for you to retire. Or, oh my God, she needs a new job. She is not interested, or he is not interested in what they're doing. I think you have to love what you do. And when you don't love what you do, go find something new. I have worked critical care my entire life, which is 40 years this year. I have been a nurse longer than most of you have been alive. It's kind of sad for me, but I have loved my job. Now, were there days that I came home and wanted to quit? Yes, of course. It's critical care. You come home and you carry a lot of weight on your shoulders. And I can't tell you it's always easy, but I always had a lot of job satisfaction. And so when I don't have job satisfaction, that's when I go look for a new job. So I've only really had 3 jobs in my life. I worked 20 years in the ICU, 10 of them as a real nurse, 10 of them as a charge nurse. And now I've been doing this job for 20 years. And when I first started this job, I thought, no, I'll just do it for a year until I find what I want to do. Because I thought I wanted to be a manager. Man, was I wrong. I think the big guy upstairs was looking after me, because I would have failed as a manager, because I would have said some few choice words to some very slack staff and I would have been in HR. So they put me in a job that I think suits me because I like it. But where do I get my job satisfaction? Get it from each and every one of you. And you're like, oh, really? I didn't know I was here for your viewing pleasure. No, you're not. But it's so nice to see people who develop passion. And I'm going to pick on Erica, for example. So, Erica, maybe a year ago, year and a half ago, came to us from orthopedics. And she's like, I think I'll like cardiac. I definitely need out of orthopedics, and I think most of us understand that. And so she went to CCU with a little bit of passion. And over this past year, just with communicating, with seeing, with looking at charts that patients that she's looked after, I can see that her passion has grown. And then I get this text, hey, Sue, I'd really be interested in taking the critical care course. And so that's where I get my job satisfaction and seeing people engaged in their job, because people who are engaged care about patient outcomes. And when you care about patient outcomes and you try and treat every patient as though they were your family, and I'm going to assume that you love your family. So I think that if you put yourself in that patient or in that family's position, that you're able to care for patients. You don't have to have this huge amount of compassion, but you have to have some empathy to understand, geez, maybe this poor guy that's laying there in the bed, his family are in Upper River Valley Health and they've sent him here in the middle of the night. Maybe he's scared. Maybe he's freaking out inside, but he's a big, strapping truck driver who's not allowed to show his emotion. And you as the nurse go in and close the door and you sit down and you say, dude, are you freaking out? Are you scared? And you sit down and you have a conversation with him. That is job satisfaction for you guys, because you go home and you're like, I made a difference today. And there is nothing in the world that replaces that. So I could go and be, I don't know, a Walmart greeter. I would nowhere near achieve the job satisfaction that you do as nurses. But also recognizing that the job frustration that comes with our lack of staffing, our challenges, it also makes being a nurse a difficult job. Now, did anybody hear this? Because some of my CCU colleagues told me this on the weekend, that Susan Holt is quite interested in giving us a retention bonus, or not a retention bonus, sorry, a thank you bonus. And that's supposed to be out by the end of the year. Did anybody hear that?
It was
Sweet.
a post on Facebook.
Okay.
And they're saying maybe they're giving it before Christmas.
I bet you got it half spent already, Delia. You've been shopping online. Sweet. Yeah, so I heard the same, that it was supposed to be a splash of cash. I don't know how much. But of course, my daughter says to me, oh my God, are you planning a trip already? I'm like, oh yeah, for sure.
They're saying it's $10,000 for this year, and then next year will be $5,000.
That's a good trip. Okay. So it's definitely a step in the right direction. So yeah, that's right, Amy. And so maybe this sets a tone for our contract negotiations. Anyway, being a critical care nurse is tough. And critical care happens in almost every area of our hospitals now. Because it's pretty hard to get into the ICU because all the beds are full. So now when you're working in step downs and those kinds of places, you're caring for critically ill patients. It's definitely a challenge. So Ima and Sarah work in kind of a unique area. They work in our cardiac surgery step down. So I will, when I'm talking about things, I may make a special reference to that just to kind of help identify the different patient populations that we have about the province. So it's 9:10. I'm gonna start, just make sure I haven't missed. Yeah, so today and tomorrow are all about 12 leads. So I'm going to share my screen with you guys. Now, I'm going to stop share just for a second. I do not normally record, but you guys can record the session if you like. So if you find down along the bottom, or some of you have it on the top, it says participants. And if you click on participants, you can find your name. And then beside your name, there should be three little dots, or there might be a more button. And it will say allow to record. I have gone in and enabled it, so some of you might just be able to click record down at the bottom. I'm not sure, but if you want to record a session, please feel free. I am recording it today so that I can give it to Sam, who is missing today because of her grandmother's funeral. So. All right, so 12 lead ECG. We're going to talk for the next 2 days about some anatomy and physiology. We'll talk a little bit about acute coronary syndromes, and we're going to focus a majority of today on the normal adult 12 lead ECG. And then we'll talk some about criteria for diagnosing a myocardial infarction. So when we look at an ECG in North America, it is always laid out in this fashion. So it has 4 columns, and in each of these columns are leads. So the first 6 that we will look at are these ones right here. And so we divide a 12 lead ECG up into contiguous leads. Contiguous leads just look at the same part of the heart. So column 1 and column 2 are called the limb leads. These are the hardest ones to kind of really understand. So we have 4 limbs, 2 arms, 2 legs, and we slap some electrodes on them, and we get 6 pictures, which is confusing to people. It's like, okay, how do you do that? We pay $65,000, $70,000 for an ECG machine. And Sarah Sipkama might stick the leads that go on the arms up here on the shoulders. And Samantha might put them down here on the forearms. And then when we put them on the legs, Erica might put them on the upper thighs, and Michael might put them down here on the lower legs. So what the fancy machine does is it changes or moves these electrodes. And from now on, I want you to think of these electrodes as cameras. And the fancy ECG machine is going to move these cameras around and give us 6 looks at the heart. This is called something called Einthoven's triangle, and it has got to do with physics and the angles. You don't need to worry about that. The ECG machine does that for you. But I'm going to show you a picture of a few slides from now that shows you where these 6 cameras sit. And this is something, and I think most of you who have heard me teach before, I am not an advocate of memorization. But that is one thing that you do have to memorize, is where the cameras of the limb leads sit. Over here in column 3 and column 4, these are easy. They sit on the chest. And we will go over where they are placed today. So going back to these limb leads, they are called bipolar. So lead 1, 2, and 3 have a positive and a negative to them. We don't care about the negative. The camera is sitting where the positive pole is. And if you can remember where the 6 of them are placed, you don't need to worry about positive or negative. And then when we look at this column, they all start with A, augmented voltage, AVR, AVL, AVF. Augmented voltage right sits on the right shoulder. Augmented voltage left sits on the left shoulder. An augmented voltage foot looks at the heart from down here. We call it the foot, or the inferior lead. And so these leads only have a positive electrode. The negative is sitting at the heart. And so the machine has to augment the voltage or make the QRS and P wave and T wave look bigger, because if the machine didn't, you and I, the humans, wouldn't be able to interpret it appropriately. So I don't want you to get bogged down in that. I want you to think of a 12-lead ECG as a group of leads looking at particular parts in the heart. So let's start with this group of leads right here. These are called the inferior leads. Lead 2, lead 3, and AVF. And they look at the inferior part of my left ventricle. They look at a little bit of the right ventricle also. Anybody know what coronary artery supplies these 3 leads in the majority of patients? If you are right dominant, I'll talk about that in a minute, which coronary artery, and you can type it in the text box if you like. You only have 3 coronary blood vessels, so you have 33% chance of getting it right. Which coronary vessel? Absolutely. My right coronary artery in about 85% of the population supplies the inferior part of my heart. So when I look at an ECG, these are the 3 leads that I look at first. And then I go on and I say, I'm going to look at V1, V2, V3, and V4, but I'm actually going to separate them. I'm going to call V1 and V2 my septal leads, and I'm going to call V3 and V4 my anterior leads. But I want you to look at this picture. So I'm going to draw you a picture of the left anterior descending artery. So here is my left main, and it bifurcates. This is called the circumflex artery here, and this one is called the left anterior descending, the LAD. And it supplies the front of my heart, or my V1, V2, V3, and V4. But the reason why we separate them is the septal branches are that piece of meat that sits between the 2 ventricles, and these are septal branches here. They are very proximal. And so if you had a lesion up here of plaque, then everything below that could be impacted if that piece of plaque ruptured. So V1 and V2 tell me about my proximal LAD. And then V3 and V4 look at my anterior heart. And so these could be mid or distal LAD. But oftentimes you will see a patient who has what we refer to as an antro or an anterior septal STEMI, where they have ST elevation in V1, V2, V3, and V4. And so I think of my proximal LAD when I think of V1 and V2. When I think of V3 and V4, we will just call it an anterior. So maybe your plaque is down further. Maybe your plaque is down here. And if it were to rupture, it would impact everything distally, but you wouldn't see any changes to your septal branch because blood would be flowing down okay to V1 and V2, would just be V3 and 4 that didn't, that's, you would see the ECG changes in. And then we have another group of leads, and this group of leads actually has 4 cameras that look at it. And it is the side or the lateral part of my heart. And if you look at V5 and V6, these look at the lateral part of my heart. And sometimes people will call lead 1 and AVL your high laterals. And for those of you that are going to work in the cath lab, high laterals, well, we'll talk about where the camera placement is and you'll understand better. These are supplied all by the circumflex. And so the circumflex is this artery here that feeds the lateral part. So if you had a very proximal circumflex lesion, you might have ST elevation in all 4 of these cameras or all 4 of these lateral leads. So as we go through, I will spend some time and focus on which coronary artery is likely the culprit lesion. And then we have this little dude all by himself. Now, last week, we talked about him in a unique way, and I will show you the same slide that we looked at last week. And this was a guy who was upside down, who had a smoke hanging out of his mouth and a gun in his hand. And I think I have that picture in this presentation again. And he basically represented everything that was negative because we said the electricity moved away from him. And so his P was negative, his QRS was negative, and his T wave was negative. And why did I put him with a smoke hanging out of his mouth and a gun? Well, that's not who you want around with you every day. It's just not really attractive. But every once in a while, that person might prove to be valuable. And we will look at some particular ECGs that have changes in lead AVR. If you had an ST elevation in AVR, so ST elevation in AVR sometimes, sorry, I didn't mean to discard all of that. So maybe your AVR looks like this and you have some ST elevation. This tells us that the patient has likely left main coronary artery disease. So when we talk about our left main, so here we are, whoops. Here we are, this little area right here. So here is my aortic valve up here. Remember, the coronaries sit outside of the heart. They lay on the surface of the heart. And so once blood exits out of the aortic valve, it will sneak down the left and the right coronaries. If I have a big lesion here in my left main, I could see changes in lead AVR. And that is kind of, it really leads you to think bad stuff is happening because when you think of lead AVR, the camera sits way up here on your right shoulder. And all the electricity moves away from him. If he is noticing by having ST segment changes, if he is noticing that bad things are happening, you can consider it a pretty significant problem. And most of the time when we send that patient to the cath lab, we see that they have left main coronary artery disease. So AVR in and of itself is not considered a contiguous lead. However, I have called physicians to say, I don't have a good feeling about this guy. He's got elevation or depression in lead AVR. And I remember calling Dr. Hubachek one night and saying, the resident won't pay any attention to me. So we had this lovely medical resident, but he wasn't the sharpest knife in the drawer. He was kind of, well, he was dumb. No other way to describe him. And I said to him, dude, you need to call the attending on call. And he's like, oh, I don't need to call. I said, well, if you don't, I am. And you will get in less trouble if you call him than if I call him. Oh, he'll holler at you. I said, no, he won't holler at me if I call him, but he will holler at you if I call him. So anyway, he was like, no, I'm not concerned about this patient. And I was very much concerned. Patient had a change in vital signs. He said he didn't feel well. And the thing that really prompted me to call the doctor was a patient said to me, nurse, am I going to die? And I tried to make light of it by saying, oh, dude, do you know how much paperwork there is for that? No way. I hate paperwork. So you're not dying on my shift. But when patients start to question that, then you know that they have that feeling. And that should raise an alarm with you. And so I called Dr. Hubachek and said, I can't give you any particular details. It's a bad feeling I have, and I see ST segment depression in lead AVR. And so he says, okay, I'm coming in, call the cath lab team. And I'm like, no, don't call the cath lab team based on my assessment of the patient. He's like, no, when there are changes in AVR, we need to pay attention to those. And so that guy came back from the cath lab with an intra-aortic balloon pump in, which is a special thing that sits in your aorta and inflates and deflates to help push blood into your coronaries. And he was a surgical consult. So I didn't feel bad about calling. I'm actually glad. Anyway, the resident says to me, oh, I guess I messed up. I said, you didn't mess up, but learn from this. Pay attention to what the people who are with the patient 24 hours a day have to say. Just because you consider me underneath you in the hierarchy of medicine does not not indicate I have less knowledge. It means I have different knowledge, and nursing and medical knowledge should come together. Neither one is superior, although doctors sometimes like to think that they have the superior knowledge. No, they just have different. But who's been hanging out with Grampy for the last 24 hours? Nurses. So that will be, for those of you who were with me last week, you know I get off on a little tangent and a rant. That will be my initial rant for today. Nursing knowledge and medical knowledge are equal. Neither one is superior. Okay, we have been yapping for an hour, so I think now is a good time to take a 15-minute break, and we'll come back at, what have I got? 9. We'll come back at 9:47 on my clock. So 15 minutes. And you can put your video and your audio on mute. Okay, who decided to come back? And who decided that they had had enough of 12 lead ECG already? Oh, a couple of you's come back. Okay, that's good. Just type in the chat box. This is just a interest of mine. Who did laundry when they were on their break? Yeah, it's who folds their clothes while they're listening to Zoom. Yeah, I'm good with that. Some people need to have something to do and to stay awake. So don't be shy if you want to get supper ready while you're doing it. Sometimes it's easier to stay focused. The other thing is I checked on D2L last night. So some of you, if you are in the critical care course, you will have access to what's called D2L. Has everybody who's in the critical care course been able to claim their account and able to access D2L yet? If you haven't, give it a try today. We haven't had a program delivery officer at UNB or the person who's supposed to help out. And it's been me now for a few months. And I'm not the best person to be helping you with UNB stuff because I know about as much as you guys about UNB stuff. So if you haven't been able to claim your account and get into D2L, please go ahead and do that. For the students that are in the New Brunswick Heart Center orientation, I printed out all of your handouts because you won't have access to D2L, but every one of these PowerPoint presentations that we're going to do for course 1, 2, 3, 4, 5, and 6 are all on D2L. And maybe at lunchtime, I'll open up my D2L and do a quick little review for you to show you where stuff is stored. The schedule for this week is we are on Zoom every day, 8:30 till whenever. And then next, it's a 3-day weekend. Monday's a holiday and you actually get off on the holiday. And then, so you might have an old schedule that says Wednesday or Thursday was a clinical day. That has been changed. So today and tomorrow we're doing 12 lead. Wednesday, we are doing acute coronary syndromes. Thursday, I think, is heart failure, and Friday is hemodynamics. And then Monday is a holiday. And then Tuesday and Wednesday, your on-site instructors will reach out to you to tell you where to go and what to do. For my Moncton colleagues, Michelle Marola has given you a clinical schedule and she will meet you. You'll just go to the clinical areas on Tuesday and Wednesday of next week. And she will meet you at 1 o'clock in seminar 1. She tells me that is in the basement of org learning. I don't know where that is, so I can't really guide you. But Michelle has said she will meet all of the Moncton peeps on Tuesday and Wednesday at 1 o'clock, and she will review the defibrillator and certify you in art lines and CVP. So if you have any questions, don't be shy, reach out. It's unfortunate that Michelle is leaving after next week. And so Moncton peeps, if you guys have any questions, I'm covering for her. So if you guys have any questions about the course, I will be your site instructor after next Wednesday for the Moncton and the St. John people. St. John people, I'm still in the process of finding places for you to go, so I will let you know where the NBCCNP people go. For those of you that are on orientation, you're going to meet me in the OPCC classroom, level 3, at 9 a.m. next Tuesday and Wednesday. Good. So if you have any questions about your schedules, don't be shy. It might appear that it's a little messed up at UNB right now, and it totally is. So I'm not going to hide that or cover it. It's a total, I'll say SS, and I think we can all fill in the blanks of what that is right now, but it's all good. So if you have reached out to nbccnp@unb.ca and haven't gotten a response, it's because the program delivery officer has been out sick and nobody replaced her. And I don't have the code to get into that UNB account, so nobody was responding to the emails until finally someone got so frustrated and sent me a text and said, "Why is nobody emailing me back?" Anyway, if you have any issues, just reach out to me. In the chat box.
I just have a question, Sue.
Yes.
So it's Zoom all week this week starting at 8:30?
Yeah.
No clinical. Okay.
No clinical.
Thank you.
And then there is going to be a day added to course 2 at the very end of it. That will be a day that's my favorite day, that you guys will be the presenters. You will be presenting a case study. And let me just see if I can open that. Schedule and show you. I can open it, just hang on a sec. So, can you see the schedule up on the screen? So, here we are, the 4th, 12 lead ECG. Tomorrow we're going to talk about myocardial infarctions and do a couple case studies. And then on Thursday, the 6th, we will do, on Wednesday, the 6th, we will do cardiac assessment and some acute coronary syndromes. Look at some cath reports. Then we will do pacing and heart failure on Thursday. Friday, we will finish with hemodynamics. It's a heavy topic for a Friday. And then you'll have a 3-day weekend, and then Tuesday and Wednesday of next week are clinical. Then on Thursday, we will do pharmacology, and Friday, we will finish kind of course 2 with valvular heart disease and infective endocarditis and a bit about shock. And then that following Monday, we will do clinical 2 days, Monday and Tuesday, and then that Wednesday, the 20th, you guys will do student presentations. So I'm going to pair you up. So on Wednesday, I will break you up into groups. And when you do your first clinical, you will find a patient that you want to do a case study on. And there's some parameters, and I'll show you what those are. And basically, you're going to present your PowerPoint presentation to the group. Each of you will participate in the speaking part and the development of the PowerPoint. And we will just all learn from each other. It's my favorite day. I get to shut up and you guys get to talk. So that makes me happy. And we'll just look at some different cases that you encountered in your clinical areas. So I will show you that on Wednesday. I'll give you the marking criteria and the scoring rubric. So that's kind of how you can divide out the work. But I will put you together in groups so that you can all find the same one patient that that works for you. Any questions about schedule this week? Yes, the most up-to-date one is on D2L. Yep. Okay. Back to 12 lead ECG. Let me open my chat. Good. So contiguous leads, 12 cameras by putting 10 electrodes on the body. So you might want to remember, whenever I say you might want to remember, that means it's probably on either a test or a assignment. So there is an ECG assignment. I actually can put it in the chat box if anybody wants it. Just give me a second. Oops, I almost put the answers. So for my orientation, ladies, you were given this in your pile of printouts, and you can give this to me at the end of your orientation. There's no particular date, just whenever. For those of you in the critical care course, you will submit this on D2L under assignments, and I will show you how to submit that tomorrow morning. It's an ECG assignment that shouldn't take you a huge amount of time. It's worth 30% of your course 1 mark. The other 70% was BCMI. So if you completed BCMI, you have a 70 out of 70 already to start your course, which you all would have had. And this ECG assignment is worth 30% of your course 1 mark. And so I just put it in the chat box. If you want to have it open, maybe I'll answer some questions for you as we go through, kind of like How many cameras does a 12 lead ECG have? It has 12 cameras by placing 10 electrodes on the heart. And Mandy, it shouldn't be in that package. That should have been all of your cardiac rhythms. It should be just a stapled one. It's like 3, maybe 4 pages, and it says ECG assignment. And if it's not in your package, you can just click on the chat box and you can download that to your computer if you like.
Yeah, I only have the hemodynamics assignment in this pack, so okay.
Sorry about that. The only person to blame for that is your instructor. I'm the one who put the packages together, so. So it is, and for those of you in the critical care course, if you want to submit that by Thursday, no, let's say Friday. So you can submit that by Friday. And if anybody's life interferes with this, just send me an email or a text. My email I put in the chat box. Here is my cell phone number. And ask for an extension. I'm easy. Hey, your life is blowing up and your kids are this and that, and you don't think you can get it to me by Friday? Just send me a text. Can I get it to you by Monday or whenever? Yeah, don't sweat it. Okay, so I put 10 electrodes on a patient and I get 12 pictures. That's because the ECG machine does all the fancy work. Very quickly, I'm going to review acute coronary syndrome, but we're going to spend some more time on this on Wednesday. So a STEMI is ST elevation in 2 or more contiguous leads. So when we think of contiguous leads, we think of these guys here that are color coded. So my inferior leads are in the yellow. My septal are in the kind of peachy color. Blue is anterior and green is lateral. So these are contiguous leads. So when people say, hey, check your lateral leads, that's V5, V6, lead 1, and AVL. And we'll talk about a new left bundle branch block. A left bundle branch block by itself is not an indication that the patient is having a STEMI. But if the patient comes in and they are symptomatic, they clinically look unwell, they're having that chest pain, and you do an ECG and the patient has a new left bundle branch block, you know that because you can compare it to an old ECG, then that's an indication that your patient is having a STEMI. So if you look at the left, let me get a better color. The left coronary artery comes down, it bifurcates into the circumflex and into the LAD. And one of the first takeoffs, that septal branch, feeds the left bundle branch. And so we say that a right bundle branch block is not really a big deal. But a new left bundle branch block is likely a proximal occlusion of your LAD. And so it becomes challenging when the patient, let's say, Sarah's hanging out at Upper River Valley Health, and Grampy comes in, and he's never sought medical attention for any reason. And now he's got crushing chest pain, but he has no previous ECG. And he has a left bundle branch block. We don't know if that's new or if it happened 5 years ago. So a lot of times the physicians in outlying regions will consult the New Brunswick Heart Center and say, hey, I got Grampy here. Clinically, he looks bad. And he has a left bundle branch block. Do you think we should give him thrombolytics? Or should we just send him to the heart center? And if we think it is a left bundle branch block caused by a STEMI, then we will often say give him thrombolytics. If you have ever heard of physicians say he meets Scarboza criteria, Dr. Scarboza was a female cardiologist who came up with some really kind of interesting criteria to differentiate between the ST elevation that happens with a left bundle branch block and the ST elevation that happens because of a STEMI. And so she came up with this criteria, and they call it Scarboza criteria. And it's a pretty complicated way of determining, is this guy's bundle branch block caused by a STEMI or not? And so there have been a few physicians who have done some modifications to this Scarboza criteria. And one of them is a Dr. Smith from the United States. He's an emergency room physician. Stephen Smith is his name. He's probably the only person I follow on Twitter. I'm not a Twitter kind of girl, but he does post an ECG there very often and kind of ask some questions about it. So he's a great teacher. And basically, he came up with a modified criteria. And the reason why I bring this up is you may hear that language working in the emergency department. Oh, he meets Scarboza criteria, or he meets Smith modified criteria. And that just basically means that his left bundle branch block is caused by a STEMI and not another reason such as fibrosis of the bundle branches. So people who come in with a new left bundle branch block in the presence of chest pain and clinical symptoms often get treated with tenecteplase, or if you're in St. John, you will likely go to the cath lab. Patients who come in with ECG changes such as ST segment depression, T wave inversion, or last week we even talked about T wave that was biphasic. So here is a T wave that is biphasic. It swings both ways. It could be this way, or it could be like that. That indicates some type of an ischemic issue happening. And if they have a positive troponin, we call them a non-STEMI. If they have a negative troponin, then we call them unstable angina. So those are the three definitions of acute coronary syndromes, and we'll spend more time on those later in the week. But you might want to remember this slide if you were doing an assignment. You can just use this slide if you like, use it word for word if you like. And go ahead, sorry. There. So A STEMI happens because of 100% occlusion in the coronary vessel. It's diagnosed by looking at the patient. You got to look at them. You got to touch them. Remember, every day last week, I said you have to lay eyes on your patient. You cannot diagnose stuff from the desk. So you look at their clinical picture, their 12-lead ECG, and we send cardiac markers on every potential cardiac patient. But if they're a STEMI, we don't wait for those markers to come back to treat the patient. So diagnosis is made within 10 minutes. So your 12-lead ECG is done within 10 minutes of entry into the ER. You're taking the ECG over to the physician and you're getting in his or her face and saying, hey, check out this ECG. And what you're looking for is ST elevation in 2 or more of those contiguous or those groups of leads. So when we look at criteria, this is the thrombolytic therapy clinical order set. This is for Horizon, and I know for Jillian and John that this is very similar in your facilities in Vitalite also. So the criteria for diagnosis of a STEMI is new ST elevation in at least 2 contiguous leads of greater than 2 millimeters in men and 1.5 millimeters in females when you are looking at V2 and V3. But all of the other contiguous leads only need 1 millimeter of ST elevation. And the reason why we have a higher threshold for ST elevation in V2 and V3 is if you look in my camera, V2, so right here is V1, here is V2, and V3. So 2 and 3 kind of sitting right here are closest to the heart, but they also, particularly in men, sit right over your chest muscle. And so we are looking at the electrical journey through the heart when we do a 12-lead ECG. So it's not the mechanical contraction of the heart, it's the electrical journey of the heart. And so sometimes that muscle in your chest elevates the ST a little bit, particularly in men, and we call it early repolarization changes. And so we just draw you what an early repolarization change might look like. So you can see that there, if I drew a line across at my PR interval, that this patient might have 1 millimeter of ST elevation. This is likely caused by that chest muscle getting in the way, and we call it an early repolarization change. And if you look at this, if my ST segment looks like a happy face, it usually is not an ST elevation myocardial infarction. This is more like an ST elevation myocardial infarction. This area right here is a sad face. This here is a happy face. I'm sad when I'm having a STEMI. I'm happy when I'm having early repolarization changes. So the threshold is a little bit higher in leads V2 and V3, So anytime you're looking at a septal or an anterior septal STEMI, the threshold for elevation is a little bit higher, 2 millimeters in men, 1.5 in women, because we don't have quite as much chest muscle. But the rest of the leads, say I was looking at the inferior leads, and they would be lead 2, lead 3, and lead AVF, then all I would need is 1 millimeter of ST elevation to meet the criteria in 2 or more contiguous leads. So that is the criteria that we have developed in Horizon, and it's very similar in Vitalite. So here's just a little bit of a summary of acute coronary syndrome. So it starts with chest pain. You're suspecting Buddy has ACS. And then your ECG is the one thing that is going to help you determine if this patient is a STEMI or a non-STEMI. So that's just kind of a little bit of a summary page. Sorry, just a sec. Sarah Sipkema posters are ready for the Heart Center Christmas party. Okay, there are 3 things that you have to remember about ECG because this will help it make sense to your brain. The arrow here represents the flow of electricity. So when electricity comes towards a positive electrode, I also call a positive electrode the camera. This is where the 12 lead ECG is standing and taking the picture. When it comes towards a camera, I get a positive deflection. My QRS is positive. When electricity moves away from the camera, I get a negative deflection. And can anybody tell me about this dude right here? What's happening to him?
You're getting a negative and a positive reflection.
Yeah, so electricity moves away initially because I get a negative deflection. And then electricity comes back towards because I get a positive deflection. I want you to think about, here's Grampy's heart. And let's say Grampy has a previous myocardial infarction. He's got a big hunk of scar on the front of his heart. So dead tissue is useless. It doesn't conduct electricity. It doesn't participate in contraction. So it's kind of useless. So my impulse comes down from the SA node. It meets at the bouncer here, the AV node, and then the electricity tries to go down. And it can't go through this big piece of scar, so the electricity travels out this way and then back down around. Well, I want you to think of this heart in this man's body. God, really bad at drawing. Here is my right side. Here is my left side. So here is the camera of lead 2. Sitting right here. This is where my camera is sitting. And so I have a P wave created by my SA node. I have a PR interval created by the time it is held in the AV node. Then I have a little negative deflection called a physiological Q wave. That means that electricity is traveling toward or down the intraventricular septum. And this is how it should normally look. But in this patient here, it's not going to look like this, because when this electricity starts to come down through this, it can't go through the piece of dead tissue, so it moves over this way. If you're the camera and your electricity is moving away from you, then you will get this big negative deflection. But then it swings back around and you get a positive deflection. So last week we talked about a deep or a pathological Q wave. This little guy right here is a normal Q wave. That is septal depolarization. And it happens from the left over to the right. That's how it normally happens. But when you have a big piece of dead tissue, you will get what's called a pathological Q wave. Pathological is always bad. Remember, I said last week, it was like Criminal Minds. When you think of that show, Criminal Minds, you think of the unsub, the pathological killer. He was always the bad guy. Pathological means bad. And so if I had 2 or more of these big Q waves in some contiguous leads, then that tells me my patient has likely had a previous myocardial infarction. So any Q wave that is deep or wide, we call a pathological Q wave, and it likely is indicative of a previous myocardial infarction. So we'll look at some of those later on today. But remember the 3 principles of ECG. Electricity comes towards you, positive thing. Electricity goes away from you, a negative thing. And then you have the dude that swings both ways, up and down, or it can also look like, and we see that a lot with really weird looking S waves. Last week when we were doing some cardiac rhythms, a lot of times that deep S wave made our QRS look wide. We don't talk much about S waves. They happen for strange reasons and nothing diagnostic or definitive. Sometimes they just happen. And it doesn't really mean a whole lot. But when we have them here before the QRS, it can potentially mean that Grampy has had a previous myocardial infarction. So 3 principles of ECG, you kind of have to memorize those. So when we talk about electricity coming through the heart, the electricity starts in the SA node. So that's our nice, normal, natural pacemaker. The electricity goes over here via Bachman's bundle. There are 3 infranodal tracts within the right atrium, and everybody meets here at the bouncer or the AV node. He's a guy who's standing there saying, look, you P waves, you can't get down into my really cool bar called the ventricles unless you go through me. And so we get a P wave created by the SA node. We get a flat line where there's no electrical activity and the AV node is holding the impulse to see if that P is worthy of entry into the ventricles. And so let me just draw you the person here. So this is my right side, this is my left side. So now, if I am the camera of lead 2, and we said most of the time we looked at lead 2 on cardiac rhythm strips, if I am in lead 2, what happens now is the electricity goes down this septum. But the way it does that is it starts on the left and goes to the right. Starts on the left and goes to the right. So if you are the ECG camera sitting right here, then you get your P, you get your PR interval, but then you get this little negative deflection. And that negative deflection is because the electricity moves away from you as the septum depolarizes. These are normal little Q waves. And then the rest of the ventricles, both right and left, get depolarized at the same time, and the electricity comes down and directly at the camera. So in lead 2, you should normally have a nice tall QRS. So that is the flow through the heart and why and how an ECG looks the way it does. So I want you to think about those 3 principles of ECG. And I want you to think about the leads that sit on the left side of the heart. So, whoops, sorry. So here's my patient. Here's the right side. Here's the left side. So I'm going to draw you in the leads that all look at the left part of the heart. Here is where lead 2 sits. If I cut across right in the middle, right about where the AV node is, that is where lead 1 is going to sit. And I'm going to review these again. And if I go up here, this is where augmented voltage left is going to sit. And down here is where augmented voltage foot. These are the limb leads that we refer to the left-sided leads. So I want you to think about all of these leads, where they are placed, and tell me if you think that they should have a positive QRS or a negative QRS. They'll be different heights, but they'll all be positive or they'll all be negative. Which do you think?
Slightly negative as it is going away from that.
So I get a little bit of Q, so that negative, yep. And then the electricity all comes to the left side. So my QRS will be positive in all of the leads that sit on the left side of the chest. And we will talk about the different heights and why in just a minute. But yeah, when electricity comes towards them, you get a positive. Thank you. Okay. Let's say I have 12 cameras and I'm going to hand them out to each of you. And I'm going to say, hey guys, I want you to go and take a picture of Heart Mountain. But I don't want everyone everyone to stand in the same spot. I want you to all stand in different locations. We're all taking a picture of the same mountain, but they're all going to look different. They're all going to have their own little unique perspective. And so here's our picture again. Here's our good-looking dude. We'll call him Michael or John or Ray or Adam. He's our good-looking guy. I always want to see him up on the screen. We'll call him lead 2. And then we'll talk about this guy. So let's say that I gave Mandy the camera called AVR. And I said, Mandy, go take a picture from way up above in the sky. She's actually got a drone and she's going to take a picture looking down. And all the electricity is going to move away from her. So Mandy's going to be this negative chick whose P is negative, her QRS is negative, and her T wave is negative. So some leads give you a better look at the heart, but I want you to think of each of the 12 leads as somebody standing in a position and taking a picture of the heart. Some are really good, some are useful sometimes, and some are useful all of the time. This is just a quick picture of electricity through SA node, AV node, bundle of His, the bundle branches, and the electricity terminates at the Purkinje fibers. I want to spend a little bit of time on coronary circulation because I think it's important. So, whenever I think of the right coronary artery, I think about leads 2, 3, and AVF. Those are considered my inferior leads, and they look at the right coronary artery in about 85% of the population. So, if you look, the opening or the ostium right here of the right coronary artery, one of the first branches off of the right coronary artery feeds the AV node. So can anybody think of what heart rhythm abnormalities would patients with an inferior myocardial infarction be more prone to? If your lesion, let's say the lesion is right here, bradycardias for sure. What kind of bradycardias? There's 4 kinds of this type of abnormalities. Yeah, heart blocks. A lot of patients with coronary, right coronary artery, more proximal occlusion. And does anybody know what I mean by proximal? It's just closer to the opening or the ostium. The opening, most of the cardiologists will call it the ostia or the ostium. And so I have minimized blood flow all the way down to the inferior part of my heart. So I said the majority of the patient population that the posterior part or the back part of our heart is fed by the right coronary artery. If you are, no, when you are born, you are either right dominant or left dominant, and that's got nothing to do with your neuro status. This has got everything to do with your cardiac status. And most of us don't know whether we're left or right dominant until we have a cardiac cath. And what that means is if you look down here at this branch of the RCA called the posterior descending artery, the PDA, in 85% of the population, this comes off of the right coronary artery and feeds the posterior part of our heart. In the other 8% of the population, and textbooks will vary with this numbers, in about 8%, this posterior descending artery comes off of the circumflex artery. So in about 8% of the population, the posterior descending artery comes off of the circumflex. And then there is even a smaller amount of people, between 5 and 7%, that they have what's called codominance, where both the RCA and the circumflex feed the posterior part of their heart. And you do not know that until you have a cardiac cath. So the majority of the population are right dominant, meaning the posterior descending artery comes off of the right coronary. So the right coronary, you can see that there's a branch to the right ventricle. This acute marginal branch is a big branch. And if you work in cardiac surgery, you will see that a lot of times we will bypass this to help improve blood flow to the patient's right ventricle and part of the left ventricle. So it is a big branch. You do see it bypassed in coronary artery bypass grafting. Now, when we look at our left main, so this area right here, it's pretty short. It's pretty short in the majority of the population. And then it normally bifurcates. You can actually see that this blood vessel trifurcates. You can see that he has the LAD. Here are your septal branches that feed your bundle branches and your septum. And you can see that they have big diagonals. We call them D1, D2. Some patients even have a D3. So when you think of your LAD, I want you to think of it laying on top of your heart. It feeds the anterior and the septal part of your heart. And when we look at the contiguous leads, we look at V1 to V4. So V1, V2, V3, and V4 all look at blood flow from the LAD. In all patients, they will have this bifurcation and the circumflex, and it looks kind of weird here, but I want you to think of the circumflex as coming around the lateral, so the left part of your heart on the side, the lateral aspect. And you can see that there are these branches called the obtuse marginals, OM1, OM2. These two are important bypass blood vessels. So you might see in a report cabbage times 5 or cabbage times 3 aorta to OM1. And so basically what they would do is they'll poke a hole in the aorta with an aortic punch. They will suture the vein graft from the aorta down here to, if this is where the lesion is, they will go distal to the lesion so that now they have blood flow down here. Sometimes if we have, let's say I had a lesion in my LAD, let's say it's a pretty proximal lesion right here. Sometimes we can use our left internal mammary artery. And the nice thing about it is it's already attached to the aorta. And so normally it's supplied over here. It gives blood flow to part of your sternum. So what we do is we come over here and we remove that from the sternum and we redirect it over here to just distal to the big occlusion. The nice thing about using the mammary arteries is you only have to have one anastomosis, and artery bypass grafts last longer than vein bypass grafts. So an artery might give you good 10, 15 years, whereas a saphenous vein graft might only give you 5 to 10 years. So we haven't developed a synthetic product yet that is acceptable. So for now, we're stuck with, sometimes we can use the radial artery. Sometimes we will use the arteries that may supply part of your stomach called the gastropoietic arteries or poetic arteries. But most of the time we will use the left internal mammary to bypass proximal LAD lesions. And the reason why we can't use it for distal, so anything that might be down here, is it's short. So we can't stretch it all the way down there. So we often use it for proximal lesions. And then this patient happens to have a trifurcation. About 20 to 25% of the population will have this one called a ramus or a ramus intermedius. And if you're working in the cath lab, you will see that this ramus can be significant in the amount of myocardium it feeds, or it can be a really small and insignificant vessel. I used to think of somebody who had a ramus as somebody who was fortunate because, wow, now they got 3 blood vessels to feed the myocardium. But there's lots of evidence to tell us now that patients who have a trifurcation will develop atherosclerotic disease sooner than patients who have a bifurcation. And that's, if you think about, if you have an intersection, the more things that you have coming in, the greater potential you have for a motor vehicle accident. So that's kind of the same philosophy in coronary vessels too. So that's just kind of a look at coronary artery blood flow. It's even more complex than this, but that's as simple as we, that's as complicated as we need to go. And let me see, I think I have another, yeah, so if you work in the cath lab, you will get familiar with these numbers and what they correlate to. So here is the aortic valve. They call it the right coronary cusp, the RCC. Oops. And you'll see the right coronary artery. So here is a proximal RCA, mid, and then distal. When you look at the left coronary cusp, you have a left main, and this guy has a bifurcation of his circumflex and his LAD, and it's just how we divide up the blood vessels. In the majority of patients who have a tri-leaflet aortic valve, they will call this cusp of the aortic valve the non-coronary cusp. But there are many patients who are born with a bicuspid aortic valve, and they would not have a non-coronary cusp. They would just have the right and the left. This is just a further breakdown of coronary blood vessels and how we label them. So I don't want you to get too worried about that, but just know, how do we know whether it's proximal, mid, or distal? Well, we have it divided up. So you can see when we look at this LAD, that D1 is considered mid LAD, but D2 is considered distal LAD. So we know that if a patient had a lesion in their D2, that they would never be a candidate for a left internal mammary bypass. You would have to go with a saphenous vein bypass because it's too far to stretch that left interior internal mammary artery down all the way to the distal LAD. All right, here is just a picture talking about left or right dominance. So the majority of the patients, the posterior descending artery comes off of the right coronary. If you are left dominant, then your posterior descending artery comes off of your circumflex. And if you have co-dominance, then blood supply from the posterior descending artery comes from both your circ and your RCA. So just a little bit of a better diagram. This guy has drawn a really long left main coronary artery. They are not normally this long. So here is a picture of the contiguous leads with the coronary artery that supplies them. So if you are right dominant, then your inferior leads, 2, 3, and AVF, are fed by the right coronary artery. If you are left dominant, then your inferior leads are fed by the circumflex. I'm not going to spend a huge amount of time on that because that's a very small percentage of the population. But I can show you a little trick to determine whether it is your right coronary or your circumflex that is feeding the inferior part of your heart. So we'll talk about that later today. There are a few influential people in my career that have given me things that have just really helped me until I could ingrain them in my brain. And coronary blood flow was one of those things that still to this day, when a patient has abnormal blood flow, I find it really fascinating because we're not all the same. We're not all these cookie cutter people, but this is the majority of the patients. And this is something that somebody gave to me 40 years ago that I stuck in my cheat sheet book so that I could look and say, okay, patient who has, patient who has right coronary artery disease, then I know that they have a potential to have junctional rhythm, because if my sinus node gets a decrease in blood flow, then I could end up with junctional rhythm. AV node gets 90% of its flow from the right coronary. So I know that when my patient has heart block, it's likely because there is ischemia to the RCA. And then as you go down, you can see which parts of the heart are supplied by which blood vessel. And so I always found this helpful to know what piece of the myocardium was being impacted so I could anticipate what kind of arrhythmias they would have, or the more that you impact the anterior part of the heart or the front wall of the heart, the more likely you are to have heart failure or poor LV function. So that's just kind of a little cheat sheet that you can stick in your little books that you will start when you start your critical care adventure. I used to have this amazing book, and it had all this stuff cut out. It was all color coordinated. It was all pretty. And it was the best book ever. And I never lent it to anybody. But there was this really hot medical resident in SICU. He's like, oh my God, Sue, I would love to borrow your book. I promise I will bring it back. And like a sucker, because he was a good looking guy and he bought us coffee all the time, I gave him the book. I never saw the jerk again. Off to Halifax or wherever he went. Anyway, that was where my book left. But it was very helpful. If any of you work in St. John and have ever worked with a girl named Amanda Doyle, Amanda Doyle has the most amazing cheat sheet books ever. They are so pretty and so legible. And I said to her, you could be a rich woman selling your little cheat sheet books. Anyway, yeah, someday she probably will retire and sell those. But this is just a little bit of what we have already spoken about. A physiological Q wave represents septal depolarization. It's small, it's really narrow, and sometimes it may not even be seen at all, even though the septum is becoming depolarized, whether we see this little negative Q or not. And a pathological Q is one that was deep and or wide and usually represented myocardial death or dead tissue. That was it. Here is a pathological Q wave. This guy is actively having a myocardial infarction, but he has stayed at home, or we have done a bad job of treating him because he has developed this Q wave. Our mission is to prevent the development of a Q wave, and that's why we get a 12 lead ECG within 10 minutes. And that is why we get TNK or a PCI into the patient very quickly, so we can prevent that development of dead muscle. He still has ST elevation. We'll talk about on Thursday or Wednesday or Thursday, the criteria for giving thrombolytic drugs. Because if you have stayed at home for too long, you're past the 12-hour window, we will not give you thrombolytics because we will probably cause more bad than good. So during COVID, we had a lot of patients who came in that had already developed significant myocardial infarction because nobody wanted to come to the hospital. Catch COVID there. Geez, dude, now you've got a big scar on the front of your heart that's going to cause heart failure, arrhythmias, and you're going to have this pathological Q wave. that almost never goes away. So that's how we tell whether somebody's had a previous infarct or not. I think now is a good break to go get recaffeinated. So let's come back at 11:15 and start back at it. Okay, does anyone have any questions before we restart and actually get into the real stuff of 12 lead ECG? Okay. All right, so pathological Q wave, he's a bad guy. A little note about T waves is T waves are weird. They're unpredictable. So when you look at a normal T wave has a different shape to it. So if you look, it has a longer upslope than it does a downslope. The first part of it's a little longer than the second half. Last week we said it was normally X amount of millimeters tall in our precordial leads. Anybody remember what that numerical value was? Shouldn't be much higher than anybody remember 5 millimeters? So it's not huge. It's not tall like this one down here that is indicative of potentially having hyperkalemia. But we get not worried, but when our T wave changes, especially in the presence of chest pain, or even if we're doing a stress test, sometimes it'll say non-specific T wave or T abnormalities, and a biphasic looking T can alert us to maybe ischemia is happening. Here is a notched T wave. Here is a slow and broad or a flattened T wave. And so what we are doing is we are comparing the ECG to the patient who's having pain to the regular ECG when he was resting and not having pain. And so you will call your physician when you see T wave abnormalities in the presence of chest pain. So I would call my doc and I would say, hey, I see biphasic T waves in my inferior leads, or I see biphasic T waves in my anterior leads. But if I don't feel confident in my ability to talk about contiguous leads, then I will just describe, I have a biphasic T wave in lead 2, 3, and AVF, and leave the interpretation to him or her. So T wave abnormalities, although by themselves may mean nothing, in the presence of chest pain, they can be very indicative of ischemia. So just be aware of that. Last week, we talked about the J point. And the J point, by definition, is where the ST and the QRS segments meet. And so we use the J point to measure ST elevation or ST depression. When you and I are looking at it on an ECG, we are going to measure our elevation from the J point. If you were in an ECG department and your patient was having a stress test, they will often find the J point, so right here, and then they would move over 2 boxes or 1.5 boxes. So if you ever read anything in the literature that says the J60 or the J80, basically what that means is it 0.6 or 0.08 seconds away from the J point? And the reason being is during a stress test, you can have ST elevation at the J point. And so when they look for ST segment abnormalities, they will move a little bit to the right of the J point just to make sure that these are not normal exercise induced changes. But when you and I are measuring it on an ECG, we are going to look for elevation or depression right at the J point. And we will draw a line across at our PR interval. And right here is our J point. Anything above this is ST segment elevation, and anything below that is ST segment depression. So here's an example. Here's my J point. So I would have maybe 1 millimeter or 2 elevation here. Look at all the ST segment elevation I have when I move out to the J80. So again, we only really care about the J60 or the J80 point when a patient is having an exercise stress test. You and I are going to measure it at the J point. The ECG department may measure it at the J60 or the J80 point. That's just to help clarify where people are measuring at. Okay, so now we're actually going to get into what an ECG looks like. So it's time to forget everything you think you know. Some of you might be asking, hey, how do we get 12 pictures of the heart when we only put 10 leads on? And some of you are saying, who really cares? I don't. I let the machine do that. And I'm probably one of the biggest control freaks I know. But that's something I can't control. So I put 10 leads on a patient and get 12 pictures. That's all good. There is really, nobody really cares where you put the limb leads, where you put the ones on the arms and the legs. But we are totally anal about the ones that go on your chest. We'll talk about that in a sec. So this is probably one of 2 or 3 super important slides for today. So I'm going to spend some time on what each of these leads will look like. But this is what the ECG machine does. You're going to put an electrode here on the right arm. You're going to put an electrode here on the left arm. You're going to put one here on the left leg and one here on the right arm. And from that, you are going to get these 6 pictures, and they are all going to be looking at the heart where this camera is sitting. So let's start with lead 2 and what he looks like. So he has a normal P wave. It's round, it's upright because it comes from the sinus node. He has a normal PR interval, and he has a little physiological looking Q, nice tall QRS, and a T wave. That's how he looks. Electricity comes down. Electricity moves a little bit away from this electrode, so you get this negative deflection right here called a physiological Q wave. It represents septal depolarization. And then the main wave of electricity comes down towards lead 2. the ECG machine will divide the heart into 4 pieces of pie, just like this. And so up at the top of the ECG, it would say QRS axis plus 60. And so what that means is the heart is divided into 4 quadrants, or 4 ways in which electricity can flow. Right here is 0 degrees, and down here is 90. So a normal QRS axis is anywhere in here. So the flow of electricity can come here, it can come here, or it can go directly down here at 90 degrees. So anywhere between 0 and plus 90 is considered a normal axis. And all the axis is the flow of electricity. An axis will help you diagnose things. So that's how lead 2 looks like. I'm going to draw you how lead 1 looks like. He has a P, normal P, little bit of a Q, an R and an S, and a T wave. Can anybody tell me why the QRS of lead 1 is not as tall as the QRS of lead 2? They look pretty similar, but in a normal heart, the QRS of lead 1 will not be as tall as lead 2. Yes, the electricity is not coming directly at it. It's over towards it, but not directly at it in a perfectly normal ECG. Now here is what AVL looks like. Why is AVL positive but really short? Again, electricity is coming to the left side, but not directly at it. Let's go to AVF. He looks pretty similar to lead 1. Electricity is not coming directly at it in most of the cases, but the electricity still comes towards it on the left side or down towards it, so it's a positive QRS. Tell me why AVR looks like this. Absolutely, that's it. Bottom line, all the electricity flows away from him. And so now I want you to think about your own family. Let's say you were a family of cameras, 6 of them. There's no way that all 6 of you are going to be normal. Think about your brothers and sisters. Think about your cousins. There's always that one unpredictable weirdo. And maybe that's you in your family, and that's okay. Well, in this group of limb leads, it is lead 3. She is the unpredictable weirdo of the group. So you can never tell what she's going to look like. She sits more on the right than she does the left. And she's just unpredictable. So sometimes she can look like this. She's often biphasic. So initially, the electricity comes towards her. So you do not usually have a physiological Q wave in lead 3. Because a physiological Q wave means electricity is moving away, and that's not happening in this example. Sometimes it's so small that you can't even see her. So just remember, lead 3 is the unpredictable looking QRS of your 6 limb leads. So I want you to think about a patient who develops left ventricular hypertrophy. So their left ventricle, enlarges grossly, and they have a whole lot more muscle mass over here. I want you to tell me why my QRS in lead 1 now looks like this, and my QRS in lead 2 is smaller. Why would I have a much taller QRS in lead 1 than I would in lead 2? And maybe AVL is taller than normal too. Absolutely. Well done, guys. This patient, if you look up at the top, it might say the QRS axis -45. So what that means is this is 0, up here is -90. And so the electricity is traveling at -45. So this might be the first indicator that your patient has had long-standing hypertension. They haven't been to a doctor in a long time, and all of a sudden they need an ECG for something. The ECG may say at the top, has voltage criteria for left ventricular hypertrophy. And basically what that means is the height of the QRS in particular leads far exceeds what the normal is. And that might be the indication to say, hey, this guy needs an echocardiogram. We need to see what his left ventricle looks like. Let's say that my patient comes in with a diagnosis of primary pulmonary hypertension. So their left ventricle is normal, but now their right ventricle is humongous because the right ventricle has had to push out against high blood pressure in the pulmonary system. And you look up at the top of the page and your ECG says axis plus 120. So here is 90 down here. Over here is 180. And so the electricity would be coming down towards lead 3. What should lead 3 look like if you have electricity coming directly at her? Is she now the weirdo? The unpredictable person? Or does she have a nice tall QRS? So your tallest QRS is usually where your electricity is flowing. And then the last scenario I want to talk about is last week we talked about ventricular tachycardia, and we said that some patients, specifically in the CCU, could have stable VTach. And that seems kind of like an oxymoron, but they're awake, alert, coherent, talking to you. So you put on a movie, monitor, oxygen, vitals, IV, and ECG. And on that ECG, let's say the impulse is coming from down here in the left ventricle. And it's spreading up this way through the heart. In true VTach, should AVR be positive or AVR be negative? Absolutely. And so if you ever had a patient who was stable in a wide complex tachycardia, we will do a 12-lead ECG. We will look at that ECG, and if AVR is positive 99.999% of the time, it is coming from the ventricles, ventricular tachycardia. And it would say, so down here, this is called right axis deviation. Over here is called left axis deviation. This is your normal. And then this quadrant up here, this piece of the pie, some people will call it no man's land. And the top of your ECG will say extreme right axis deviation. Extreme right axis deviation. So that's how 6 of your limb leads will appear. And we're going to go over this again at the end of today, just to help you make sure that you understand what they look like. So 6 leads all have a different look because of the way the electricity is moving towards or away from them. And then the precordial leads. So I have this really cute guy at UNB. His name is Brock, and he is the graphic designer for a lot of the pictures that are here and a lot of the pictures that are on your modules in D2L. And sorry, the ladies and gents that are not in the critical care course do not have direct access to those modules. I will find the link. It's kind of like your online textbook for those of you that are in the course. And for those of you that are not in the course, I will post a link in the chat box later today that you can actually go in and look at the materials. But Brock has drawn the pictures and he's done a very good job. There's a couple of them that I asked him to correct, and he's like, really? Do you know how much work that is? Like, no, just make it happen. I said, Brock, if you could just move V2 over just a very small, so that it's up against the septum or the sternum. And he's like, really? It's that big a deal? I said, yes, it is. So I want all of you to take your fingers and spread them out. And then I want you to put your index finger on your collarbone on the right side. And where your baby finger lands is your fourth intercostal space. So you can try and feel through the fat and find your intercostal spaces, or you can do this. If you're doing it for a patient, ask them to put their fingers on, and this is where V1 is going to sit. So you're sitting on the right side of the chest. I'm going to tell you that V1 is the most important lead of your precordial leads. Because she sits on the right side of the heart or the right side of the chest, we are going to look at her often. And then directly across, still the fourth intercostal space, but now the left sternal border is where we're going to put V2. Then you're going to skip V3 and you're going to go to V4. You're going to go mid clavicle and you're going to go to your fifth intercostal space and you're going to put V4. Directly beside it is V5 and directly beside that mid axillary is V6. We'll also look today at posterior leads and how we would place V7, V8, and V9 if you needed to do a 15 lead ECG. So then you come back and you place V3 halfway in between V2 and V4. And if you're doing an ECG on a lady, it will always be on breast tissue, whether it's that saggy old tube sock breast tissue or whether it's robust tissue. Women are so much more challenging than men. You got to lift boobs up out of the way to get V4, 5, and 6 place. They're just annoying. Men are so easy for a couple reasons. If you say to a man, can you take your clothes off? All of a sudden they're naked. It's like, whoa, buddy, you can leave your underwear on. No. You tell them to get naked, they get naked. And they let you do anything to them. They just lay there. They don't ask questions. Isn't that right, Adam? Men are easy. Women are more challenging. So that is placement of your leads. And so how do they look? So this picture is kind of how we're looking at the heart with our chest leads or precordial leads. It's like we have cut the heart into in a cross section, right about the AV node. The limb leads looked at the heart up and down this way. We call it frontally. And the ECG electrodes of the chest look at things in a cross section. So just a little bit different look at the heart. Okay, so when we had the cameras of the limb leads, I said that was an important picture or a slide. This is another important slide. So this is called R wave progression. And so I'm going to draw you the heart. No, let me do it a different way. This is my dude. He's kind of lopsided. So this is the left side of his chest. This is about where a perky nipple would be. And this is the right side of the chest. So here's my big heart. So my impulse starts at the SA node, goes down, AV node, right bundle, to left bundles. So if I am V1, V1 will always be negative in its QRS. The T wave should be upright, or it can potentially be inverted a bit, but the majority of the time, your T wave is upright. So I would like you guys to fix this and put in an upright T wave. So initially, you might get a small positive deflection in V1. And that is because the septum gets depolarized from the left over to the right. So remember, this is a lead sitting on the right side. Can anyone tell me why V1 should always be predominantly negative when you see this wave of electricity moving through both of the ventricles? Absolutely, the main wave of electricity is down and to the left. So if you are the lead of V1, initially electricity came towards you because the septum got depolarized initially. And that's what this little positive deflection is. The majority of the time, you may not see this, especially on a chubby person. But then the main wave of electricity is down and to the left, so you get a very negative deflection to V1. V2 is very similar, so now you've moved over to left sternal border. You're on the left side, but again, it moves away from the heart or from that camera. So you get a negative deflection, but you might start to see a little bit more positive to the first part of the QRS. Remember I talked about lead 3 being the deviant, unpredictable one in the limb leads? Well, V3 in the precordial leads is also unpredictable. She is called the zone of transition, and she swings both ways. First, electricity comes towards her, so you get a positive QRS. And then electricity moves away from her, and you get a negative deflection. And so at the top of an ECG, you will see normal R wave progression written sometimes. And what that means is that V1 and V2 are negative, and that V3 is where the QRSs start to transition into positive ones. And if the ECG said early R wave progression, then it means that the zone of transition happened before V3. And if you see late R wave progression, then it means that that biphasic or QRS that swings both ways happens after V3. That's all that means. And it can be a normal variant. It can't really, it means nothing without looking at the clinical picture. Now, when we get to V4, 5, and 6, I had to draw in these little Q waves. And Brock said to me, does it really matter, Sue? Like, I said, yes, it really matters. What do these little Q waves in V4, V5, and V6 represent? What piece of the myocardium is being depolarized when you look at these little Q waves? What do they represent in leads that sit specifically on the left side of the chest? What piece of myocardium? Yeah, it's the septum getting depolarized, and they do it in the opposite direction, from the left over to the right. That's why V1 has a little positive deflection to it, because it's sitting on the right side of the chest. When electricity from the septum moves from the left over to the right, it comes towards V1. But then the septum is all done being depolarized, and the ventricles now get depolarized. So you get this deep negative deflection of V1. So V1 should always be negative. V2 should be predominantly negative. V3 should be the zone of transition. V4, V5, and V6 will all be positive. And V5 is very similar to lead 2. Electricity comes directly at him, but remember, this set of leads look at the heart this way, cut across, and lead 2, because it's a limb lead, looks at the heart up and down frontally. So what we have just done is we have gone over a normal 12 lead ECG. We have looked at all 12 of the leads and how they would look or should look. So now I would like, so for some of the people last week, we used the annotate button. So I want you to find the little toolbar. You'll have to move your mouse around, and a lot of times it will drop down. Mine drops down where it says Sue Morris is sharing her screen. If you move your mouse, so I want everybody to see if they can annotate. You can either stamp with a check mark or a heart, or you can use the pen and you can draw. So everybody try and get a feel for that. If you're on a Mac, it's much more challenging to find that. But sometimes if iPad is the most challenging, if you're on a Mac notebook or a desktop, it drops down from the top. So I can put hearts all over the place. I can draw with different colors. This happens to be my favorite color. Pink fuchsia. So if you don't have the annotate button on your computer, don't worry. You can type in the answer to the chat box. So I'm going to clear all of our stuff and I'm going to ask you about different leads, and you guys are going to identify the lead. So you can type it in the chat box, or you can circle it. You can put an X or a stamp, whatever you like. Okay. I am the lead that is the best look at the heart. And so I would like you guys to take your pens and I would like you to draw a taller QRS in lead 2 than Brock has done here. He's like, oh, well, that's not a big deal. I'm like, yes, it is, Brock. So make your QRS taller in this example in lead 2. It should be as tall as V5. Okay, I am the lead that should be normally negative. I am the negative Nelly of the heart. My P is inverted, my QRS is inverted, and my T is inverted. Well done. Well done. Okay, I am the best looking look at the heart when you cut me in half at a cross section. Yeah, well done. V5. So you can see their close proximity. V5 and lead 2 sit very close to each other. One looks this way, one looks this way. I am the 2 unpredictable leads in the heart. You never know what I'm going to look like. Yeah, my 2 3s. Lead 3, you can see in this example, lead 3 looks really bad. And V3 should be my one that swings both ways. Lead 3 and V3. Yeah, absolutely. Who sits on the right side of my chest and will have a negative QRS and usually an upright T? Yeah, well done. V1. I sit at the level of the AV node on the left side of my chest. I sit at the level of my AV node. Yes, lead 1. So if you think about my AV node is right about here. Lead 1 looks in at my heart right around the AV node, right where hopefully perky nipples should be. I am a lead that looks at the inferior part of my heart from the foot. Augmented voltage foot, absolutely. Inferior part of my heart. I am considered one of the 2 high lateral leads. This is the lateral part of your heart. Who am I? My QRS is not very tall. Yeah, well done. augmented voltage left. And so what I want you to do is I want you to come to lead 1, and I want you to make lead 1 a little bit taller than lead AVL. So lead 1, make it a little bit taller in this picture than AVL. I am the 3 precordial leads that should have Q waves and positive QRSs. I am the 3 precordial leads. Yeah, V4, V5, and V6. And that, guys, is how a normal 12-lead ECG looks. So now you might not know what the heck is going on, but you know it's not normal. When you look and you see a positive QRS in V1, you'll be like, what the heck? And later today, we'll learn that there are 5 reasons to have a positive QRS in V1. And we'll talk about those. So now I'm going to erase all of your hard work, and we're going to start again. And I would like you to identify the 3 contiguous leads that look at the inferior part of my heart. And feel free to turn to slide number 1 to look at that. Woohoo! Well done. So you said lead 3, AVF, and lead 2. So can you see how they kind of sit down here at the bottom? And look at the bottom of my heart, my inferior part. Well done, well done. Now, I would like you to circle the 2 leads that look at the intraventricular septum, this piece of meat here. Yeah, V1 and V2. Well done. Well done. Now I would like you to circle. There's 4 cameras, but I want you to circle 2 of them that look at what we call the high lateral part of my heart. So lateral being here. Yeah, lead 1 and AVL. Yep. Now, what if the lateral part extended down here? What other 2 cameras would look at that part? Yeah, V5 and V6. Yeah, well done. And what 2 leads look at this part of the heart, also called my anterior? Yeah, V3 and V4. So what if, imagine Grampy comes in and he has a lesion way up here in his LAD that is impacting this area and this area. What are we going to call that kind of infarct that covers, that has ST elevation V1, V2, V3, V4, V5, and V6? other than holy crap. So V1 and V2 take into account the septum. V3 and V4 take into account the anterior. And V5 and V6 look at the lateral. So this would be an anteroseptal lateral infarct. And I have no idea why we put the anterior first, the septum in the middle, and the lateral last, but that's usually how. Or a left main infarct, absolutely. Yeah, that's a huge infarct. Yeah. Well done. Well done. So you might want to remember this picture for an assignment. There's some easy marks. That's it. This is where they look at the heart. And you guys need to appreciate this picture because I got a write-up on my HR file for this. So my boss calls me and she says, Sue, and you have to know my boss, she is the kindest, sweetest person ever. And she's laughing and she said, I know you, so I can ask this question, but were you looking at pornography at work? And I started laughing. I'm like, oh yeah, Janine, that's what I do on my days off. I come into work and I look at pornography. And she said, well, I got a report from the IT department that you were putting in inappropriate requests into Google. And I'm like, what? So she said, well, it was this day at this time. And so I look back and I'm like, well, I was doing a 12 lead ECG presentation. I was putting it to, like, oh, I typed in naked male torso because I needed a picture of a man's chest. And she said, yeah, so you now have something on your HR file. She said, you can fight it. I'm like, I could care less. I'm not applying for another job, but it was quite funny. So that picture of that man will help you do an assignment question very easily. Okay, let me see where we're at slide-wise. We're about 20 slides. So I think now is probably a good time to do lunch. So you guys type into the text box whether you want 30 minutes or 45 minutes, knowing the longer you take, the longer you're here. So I don't care. I work till 4 o'clock. So 30 or 45 doesn't matter to me. Looks like 30 is winning. Okay. So let's come back at 12:40 and we will start and look at some real ECGs. So see ya in 30 minutes. Did anybody want to come back after lunch? I'm under no delusion that I am your priority in life. I get that. However, here we are. We're gonna finish 12 lead. So you got the normal basics. Sorry, I just have a boss who's texting me. Poor Jenny is trying to get people into skills and the so we're just trying to get everybody certified in all of their things before the end of the year is always a challenge. So sorry that I am texting in the middle of class. Right, okay, so let me share my screen again. Okay, so let's talk about the important part of why we do a 12 lead ECG. We want to look and see if our patient's symptoms are matching what our ECG or vice versa. So when someone complains of ischemic pain, what are some of their clinical signs and symptoms? How would you question? Yeah, and what's specific to their pain? How do they often describe their pain? Is it a ripping, tearing? Yeah, it's crushing, it's heaviness, it's tightness. They'll often say, I feel like an elephant sitting on my chest. Yeah, and some people don't use the word pain at all. They say, my chest feels heavy. And so when we describe chest pain, we ask the patient to be specific because those are words that cardiac patients use. It's heavy, I have a discomfort, I have pressure. It feels like the worst indigestion I've ever had. But when patients say, I feel like a ripping, tearing chest pain is happening, then you should be saying something else in your brain like, I wonder if this is an aortic dissection. So patients who come in with aortic dissection have a ripping, tearing chest pain. And so if we give those patients TNK, then we're going to kill them. And so when patients say ripping, tearing chest pain, we automatically check the blood pressures in both arms. Because if you have an aortic dissection that's moving up into your ascending aorta, it may impact your left subclavian and you will have a lower blood pressure in your left than in your right. And so that is why when a patient comes in with chest pain to the emergency department, it's important to do a blood pressure check in both arms. You chat to them, you feel them. Are they cool and clammy? Are they warm and dry? And you ask them, Do you have a history of angina? If they do, is this like your typical angina? Oh no, dear, it's a lot worse. But is it like your pain that you have with your typical angina? Did you take nitro for this? Did you get relief? Who are the two patient populations that will present atypically? Oh yeah, you gotta love the women. The women and the diabetics. So if you're a diabetic female, you're probably going to present in an atypical fashion where you have pain in your lower arm, you have pain in your jaw only. You might not have pain at all. You might just have this extreme fatigue. So diabetics and women present atypically. So there are three things that we talk about when we talk about lack of oxygen to the myocardium. We talk about ischemia, injury, and infarction. And when we talk about ischemia, we talk about T wave and ST segment depression. So we could have T inversion, we could have a biphasic T, but we can also have ST segment depression. That is kind of like, hey, pay attention to me. I'm not getting enough oxygen here. And then if we don't resolve this, it can go on to what we refer to as injury. Injury is ST elevation. It's more of a, hey, you really got to pay attention to me here, because if you don't fix me pretty darn quick, I am going to turn into this guy, which is called infarction. And you can see that this patient has a deep pathological Q wave indicating that my patient has had muscle damage. And one of my very good friends is a neurosurgery guru for St. John. And Lupti often says to me, the heart is merely a muscle, Susan, not like the complex organ that I hang out with, the brain. And last time I checked, myocardial cells do not regenerate. Damn it, she's right. They don't. So, which of these three scenarios is not reversible? Yep, the infarction. Once you killed it, you can't regrow it. No, that kind of sucks. Unlike the brain that can regenerate itself sometimes. So yeah, we always have that. She has a cup that says she's the brain and she's hanging out with stupid, pointing to me, the heart, and I have the opposite. We love to chat back and forth and joke back and forth about whose organ is better. But ultimately, we know that one cannot exist without the other. So, yeah. Okay, T-wave inversion. It can be as important as ST segment depression. Okay. I'm going to give you a scenario. So, 56-year-old female comes into the emergency department. She is complaining of a heaviness in her chest, and she was moving her fridge so that she could clean behind it. Moral of the story is, don't clean, you won't have these problems. However, she decided to, and she arrives to the emergency department. And so she has an ECG within 10 minutes of arrival. and you and I are going to take this apart or look at it in contiguous leads. So, first set of contiguous leads we are going to look at are called the inferior leads. 2, 3, and AVF, inferior, supplied in 85-ish% of the population by the RCA. So, first thing I'm going to do is I'm going to take my trusty pen and I'm going to draw a line at my PR interval. And what I'm going to notice is my ST segment is okay, but I have a biphasic looking T wave. Okay. So then I go on to my second lead. And remember I said that lead 3, she's the weirdo. Well, look how weird she is here. God, I don't see anything except my T is bigger than my QRS, which I just note, but I don't have any ST segment deviation. And when I do lead AVF, he's okay. This one's okay, even though it's weird. So I have to have things in 2 or more contiguous leads to be suspicious. So I'm going to say, RCA, I think you're okay. So then I'm going to move on to look at my next group of contiguous leads. And so I'm going to look at V1, 2, 3, and 4, but I'm going to subdivide them. And I'm going to look at V1 and V2 first. So I look at V1, I don't get overly excited by anything. She's predominantly negative, which I'm happy with. But when I look at V2, I see this big T inversion. And when I look at V3, I see this huge T inversion. And in V4, I see ST segment depression and T inversion. So what coronary blood vessel am I concerned about with when I look at these 4 leads, breaking them up into septal and anterior? So this is a septal lead, this is a septal lead, this is an anterior lead and an anterior, and yes, I am concerned about my LAD. But I'm not done. I still have, sorry. I still have 4 cameras to look at. So let me get another color. I'm going to look at V5 and V6, lead 1, and AVL. 4 cameras for my lateral leads. So here we have ST segment depression, or sorry, T wave inversion, T wave inversion. Sorry, just answering a text here. T wave inversion, T wave inversion. So which coronary artery would this indicate ischemia is happening to? Yeah, my circumflex. So, does anybody think that 2 coronary arteries can have problems at the same time? How can that happen? Do you think a piece of tissue over here in my circumflex is annoyed and a piece over in my LAD? Or, as you have alluded to, well done, guys, a very proximal this could be this patient's left main, or it could be what we refer to as, so here's my left main, here's my circ, here's my LAD. It could be up here in the left main, impacting flow to both of these, but it could also be a lesion sitting here at the bifurcation. So anytime there is a bifurcation or a trifurcation, it is an area of plaque formation. But I'm not going to have a piece of plaque down here causing problems in my LAD and a piece of plaque over here causing problems in my circ at the same time. So when you see this, where all of these leads are being impacted, I want you to think more proximal disease than distal disease. So this is a big deal. This is actually a very huge deal. And now I want you to, before we call our doc, I want you to tell me what is abnormal in AVR. Remember, he's my negative Nelly. Everything about him is negative. Yeah, his T wave is upright. That is abnormal. That's a big deal, and that can be indicative of left main coronary artery disease. So it's a big deal. When I call my doc, hey doc, I'm calling you about the patient in 50A or the patient in the emergency department, and they have T wave abnormalities in V1, 2, 3, 4, 5, and 6, plus lead 1 and AVL, or I could say all of my left system, circ and LAD, and I have an upright T wave in AVR. So you don't have to describe it as anterior, septal, and lateral. You can just say the leads that you see it in, but make sure that the doc knows this, because that could be the difference between coming in at 2 a.m. and sending the patient to St. John the next day. You might be sending this patient to St. John in the middle of the night. Or if you are in St. John, they might be saying, okay, get them ready to go to the cath lab. We'll call the team in. If you're coming from another facility, then it gives them a little bit of time to get in and get ready. But if you work in the cath lab, you are supposed to be within 30 minutes of your place of employment when you are on call. So a couple of girls live on the Kingston Peninsula here, and that does prove to be a challenge. Some of them will stay at people's homes when they are on call. It's challenging, and we don't have enough staffing for a 24/7 cath lab. There are no 24/7 cath labs in Canada, although they are always on call. Even in the bigger facilities like Vancouver and Alberta, their cath lab staff stay in-house until 11:30 at night. And then if they are on call, some of them will sleep in hospital, and some of them will be within 20 to 30 minutes of being available. So we take lots of patients to the cath lab all night long. If you're on call, you are likely coming in. If you're on call for a weekend, I don't know that there's ever been a weekend in the past 10, 20 years that you haven't come in. It's a guarantee, it's a given. And on the Cath Lab Facebook site, oftentimes I will see, hey, can anybody cover me? I have a sick kid. Because you know you're coming in. Because we are, all STEMIs will come here. If STEMIs have failed their reperfusion with tenecteplase, then they will go directly to the cath lab. If they are pain-free, then they will go to the cath lab within 24 hours of administration of TNK. But if they have failed their thrombolytics, they will go to the cath lab in the middle of the night. Any comments or questions about this ECG? It's pretty significant. It's really, the T wave really catches your attention. So the only lead that really should have a T wave in the negative direction is lead AVR. And even that is messed up here. So upright T's are where it's at. Oops. So the zone of ischemia is sort of the first 20 minutes when impaired blood flow occurs. It's reversible, it's temporary, and we will see ST segment depression or T wave abnormalities. We call it the zone of ischemia. And then if we don't address that ischemia, it will go on to becoming an acute reduction in blood flow, which is between 20 and 40 minutes. So you've ignored the ischemia and it's gone on to injury. And how do we know that? By looking for an ST segment elevation. It too is reversible if we can get to it in a timely fashion. But then we don't get there, and within 1 to 2 hours, you have a piece of dead meat. That is the zone of infarction. Even though we call it an ST elevation myocardial infarction, it truly isn't an infarction until we see a pathological Q wave. We call it a STEMI, ST elevation myocardial infarction. But if we can get TNK or a PCI into the patient in a timely fashion, then we can prevent the development of a pathological Q wave. So we still call it an MI, but our whole goal is to prevent tissue death. And so we are pretty crazy about time management. So this is where my colleague, Lupti, the neuro guru, and I really differ. So because of the work done by Heart and Stroke, because of the randomized control trials out there, we all know that time is muscle. When someone comes in with an infarct, we are right on top of them. We are trying to get treatment to them as soon as possible. I think our colleagues in the stroke world are about a decade behind us. And many years ago, there was this cute little boy. His name was Dr. Greg McLean, and he was probably one of our province's best stroke neurologists. And I sat on the board of Heart and Stroke Foundation for New Brunswick at that time. And Dr. McLean joined, and he came into the room where we were having a meeting, and Greg's kind of a rough and gruff kind of guy. And he looks around and he introduces himself, and He's like, oh, Morris, I know you. I'll sit beside you and annoy you. He said, but does everybody know why I joined the Heart and Stroke Board of Directors? We're like, no. He said, because I am a self-serving, and he used a derogatory word that I won't say, I am here to make stroke care as accessible as STEMI care. So we said, okay, well, what's your proposal? So he said, I want to go to the New Brunswick legislature with the support of Heart and Stroke and tell them that Heart and Stroke will give us X amount of dollars if the provincial government will fund the rest of a stroke team or a stroke initiative. And so the president of the board of directors asked us all to think about it, and we dedicated $250,000 to purchasing stroke, we call them Tambergs, or it's basically video equipment so that the neurologist can be in his or her home and can assess the patient in the emergency department. So we go to the New Brunswick legislature. Greg says to me, can you come with me, Morris? And I'm like, I don't really want to speak in the legislature, thanks. He's like, no, you just come and be my eye candy. Like, sure, okay. So we go to the legislature, and Greg, who's not usually a really professional guy, he was all dressed in his suit. And he got up and he gave a presentation. And the presentation was professional, but not truly impactful. And so he sat down and he whispers to me, he said, do you think they get it? Like, no, I don't think so. So I was packing up, getting ready to leave. And so he says to me, are you ready? Are you with me, Morris? And I'm like, what do you mean? He said, are you with me? I'm like, sure, what are you going to do? So he slams his fist down on the table that we were sitting at, and he says, just a moment. So here we are in the provincial legislature with all the MLAs and the premier. And he says, I'm going to speak to you people in a language that you will understand. He said, dollars. So he goes through and he gives this scenario of a 45-year-old woman that comes into the emergency department with a stroke. Nobody pays attention to her because she's aphasic and can't speak and holler. And so they park her in a corner and she digresses and she gets to go to the ICU. And so he's adding up the cost of this. And at the very end, he says, and this woman goes to a nursing home at age 45 and never pays another dime in taxes. Well, the Minister of Health stands up and says, we'll find you money. So when you can prove that things can be cost effective, people start to listen. And so we developed New Brunswick Telestroke. And telestroke has been slow to catch on because I don't think that neuro patients have the number of advocates that cardiac patients do. And so if you are a nurse working in the emergency department, please know that stroke care is equally, if not more important than STEMI care. Now in St. John, I can say that for a long time we sucked. Oh my God, it'd be bad. Until we incorporated 2 resource nurses into our emergency department, and they have become the stroke advocates. And I'm sure that they will do a presentation, but the difference that those 2 nurses have made So just because you are a nurse, don't think your voice is not heard. Greg McLean said to me, the most annoying thing in the world is the nurse who thinks she can save a patient and calls you repeatedly all night long. He said, I love that because squeaky wheel is going to get the grease, meaning the person who you're advocating for will receive the right kind of care. So that is my rant for today, that neurocare is as important, if not more so, than STEMI care. And I know that heart and stroke have always had a bigger focus on heart than they have had stroke. I'm not really sure why. But just remember, doing a ECG and doing a CAT scan are kind of the equal thing, one for the heart and one for the brain. So don't let some cute little physician tell you, yeah, we'll just do a CT scan in the morning. Sorry, that's way too late. Okay, that's my rant. Okay, so here we are, kind of what happens when you have a STEMI. So you're hanging out at home and you're in the normal QRS ST segment zone. Life is good. And then all of a sudden you start to have 100% occlusion of a coronary vessel. First, what happens, which isn't on here, is you get what's called a hyperacute T wave. We rarely ever see this because it happens when the patient's at home, when they're starting to think about, oh, should I take my Dival? Now, if somebody were infarcting in front of you, say you were on a surgery floor or medical floor and your patient was in with something else and all of a sudden they developed a STEMI, you might see this hyperacute T wave, but this usually happens when they're at home. And then they decide, oh, this isn't getting any better. And by the time they arrive to us in the emergency department, they have ST elevation. If we do not treat them, you can see the development of pathological Q waves. Your ST is still elevated and you may develop T inversion. But look, weeks later, this pathological Q wave has not gone away. Years later, this pathological Q wave may not have gone away. So we want to intervene right here so that we can prevent this from happening. So the sooner you do, the less infarct trauma there will be and the less fear of Q wave development. So we do not want to see pathological Q waves because that tells us dead tissue. Now, there is something in the presence of a STEMI called reciprocal changes. And basically, it is the lead that is the leads that are facing the part of the heart that is having a STEMI that would have ST segment depression or T wave inversion. So reciprocal changes are additional confirmation that your patient is having a STEMI. And we'll look at a couple of these just in a minute. So I really liked the way that one of our senior cardiologists explained it. So the resident says to him one day, Dr. Marr, I don't really understand what reciprocal changes are. And maybe an inappropriate response, but he says, well, I think if you're stupid enough to miss the ST elevation, God is giving you a second chance to save the patient's life by giving you ST segment depression. That's not really what it is, but in the presence of a STEMI, sometimes the other parts of the heart react to what bad things are happening, and what they do is they start to drop their ST segment. Whenever you have ST elevation in 2 or more contiguous leads, and you also have ST segment depression, the problem is the elevation. So I always say it as a STEMI trumps everything. You're not having ischemia in the areas that has the ST segment depression, but rather you are having a STEMI in the area where the ST is elevated, and these are additional confirmation that the patient is having a STEMI. So reciprocal changes happen fairly often, and they are just described as ST segment depression or T inversion in the presence of a STEMI. And so we'll look at a couple of ECGs. Here is just a reminder that contiguous leads and who supplies them with blood. And so I'm going to give you guys a couple of minutes, and I would like you to answer the 3 questions that are down here. Is it ischemia or infarction? What coronary vessel do you think is impacted? And don't worry about the treatment. We'll talk about that later in the week. No problem, Erica. See ya. And if you'd like, go ahead and type in the text box what you think is happening in which coronary vessel. Ready, let's start. I start at my inferior leads, but you can start at whatever contiguous lead you like. And so I see that I have some ST segment depression in lead 2. Lead 3 is okay. And maybe 1 millimeter of ST depression in AVF. So I'm kind of wondering, before I look at the rest, do I have 2 contiguous leads that maybe have ST depression? I might. This might be a millimeter or so. So I go on and I say, oh crap, look at the ST elevation here. And I say, oh crap, ST segment elevation in V1 and V2. So I know I have a septal STEMI. And so I should be thinking, oh, this is proximal LAD. But I'm not done yet. I need to go forward and I see ST elevation in V3 and V4. So I know that I have an anterior, or some people call it anteroseptal STEMI. But I'm not done yet. I need to look at my lateral leads. I don't get truly excited about V5. V6 has a little ST segment depression. When I'm looking here, don't get hugely excited. And then I have some ST segment depression in lead 1 and a little bit in AVL. So what I am seeing in my lateral leads and my inferior leads are reciprocal changes in the presence of an anteroseptal STEMI, ST elevation myocardial infarction. And I would be thinking that it was my LAD and probably more proximal than mid or distal. How am I going to manage this guy? Well, we're going to talk about that on Wednesday. There's really 2 possible treatments. TNK, if you are not able to get the patient to the cath lab within 30 minutes. Nope, I'm lying to you. Within 90 minutes. Sorry. So if you cannot get the patient on the cath lab table with the balloon angioplasty balloon inflated within 90 minutes, then your treatment is TNK. And when you decide to give TNK, we want it to be given within 30 minutes of medical contact. So I think I got on a rant last week about thrombolytics in the field. And we are one of the last provinces in Canada to adopt that. I hope that by the time I get ready to retire, which is about 4 years from now, that we have thrombolytics in the field. So if you go to our sister province, Nova Scotia, they have had thrombolytics in the field for about 28 years now, meaning their medics do a 12 lead ECG, transmit it to the nearest hospital, and we know technology is available for that. It was 28 years ago. It must still be, or a little bit better now. And the emergency room physician decides, yep, this is a STEMI patient, do a checklist to figure out if they are a bleeding risk. And if not, go ahead and give thrombolytics in the field. So the medic gives the TNK in the field and they bring the patient into the emergency department. Like Nova Scotia, we only have one cath lab in New Brunswick. They only have one cath lab in Nova Scotia. So if you are in Cape Breton, you have just saved a significant amount of muscle, because now you are bringing that patient into Halifax to get his PCI done. Same within New Brunswick. Now, a lot of times, Edmundston will go to Quebec City because the ride is faster. But the rest of the province will come to St. John. And so we look at both of these treatments as equal when you think about the time. Imagine if you had to come from Campbellton all the way down to St. John in an infarct, you would probably have a pathological Q wave develop by the time you got here, because time is muscle. So this patient would get TNK and then come to St. John after that. And we'll talk about our drip and ship program and what that actually means when we do acute coronary syndromes later this week. We don't have to do this one, but this is just another patient who has reciprocal changes. So you can see these nasty, nasty ST elevation here, ST elevation here, ST elevation here. Maybe not so much in V4. But look at all of your inferior leads. These are reciprocal changes, this ST segment depression. This is an anteroseptal STEMI who has reciprocal changes in the inferior leads. And all reciprocal changes is just additional confirmation that bad things are happening. All righty. Anybody's brain getting full? Yeah, it's getting to be that time of day. I would like you guys to do this ECG. And just type into the text box what kind of acute coronary syndrome you think it is. Yes, it's definitely looking like an inferior infarct to me. So inferior infarcts are kind of cool because remember, the right coronary artery comes down and there is this tail on it called the posterior descending artery, PDA, which feeds the posterior part of our heart. So I want you to keep that in mind whenever you have an inferior STEMI. So it's very apparent. First of all, I noticed that the guy is in first-degree heart block. That's the first thing I noticed. Normally, there is a lead 2 rhythm strip at the bottom. And you can tell that's one of the first steps of a 12 lead ECG is rate and rhythm. But we beat this to death last week when we did 5 days of rates and rhythms. So this guy has first-degree heart block. And when I look at his PR interval, I see ST elevation in 2, ST elevation in 3, and ST elevation in AVF. I know immediately that this guy is an inferior STEMI. So I always want to go and look at the rest of my ECG. So I see ST segment depression in V1 and V2. We are going to come back and talk about this because it's unique to inferior infarct. So I have ST segment depression in 3, 4, I'm not getting excited about. 5, I see some depression. Sorry, gotta move my chat box here. 6, I'm not getting too excited about. Lead 1, I have T inversion, and AVL, I have depression and T inversion. So I know I have an inferior STEMI. Whenever you have an inferior STEMI, I want you to go to leads V1 and V2. And when there is ST segment depression in V1 and V2, this is an indicator that the patient is probably an inferior posterior myocardial infarction. And this guy needs a 15 lead ECG. So whenever you have ST segment depression in V1 and V2, it can indicate septal ischemia, but it can also indicate a posterior MI. And so we are looking at the front of the heart. If we're looking at the back of the heart through the front, then you get depression. And that is a sign to say, hey, go ahead and do a 15 lead ECG. So here we are, 15 lead ECG, V7, V8, and V9 are in the same plane as V4, 5, and 6. They are just on the left posterior chest. And so what you will see is ST elevation in 7, 8, and 9 if you have a posterior infarct. You might even want to do a right-sided ECG in the presence of an inferior STEMI. And that is because a big part of the right ventricle is fed by the RCA. And so we don't have many leads that really look at the right ventricle very well. So what the doc will ask you to do, not you, the technician, but it may be you in a smaller facility, is you reverse your leads. And so V1 is now on the left and you are working your way to the right. And some doctors will ask you to take V4 and move it over to V4 and only do a right-sided V4 because that will give you the best look at the right ventricle. So you do a posterior or a 15 lead ECG if you are questioning a posterior extension to your inferior infarct. If you are talking about an inferior infarct, you could also have with right ventricular extension. And that is when you would do a right-sided ECG along with your traditional 12 lead. So an inferior STEMI has a few little nuances that you need to remember. Always look at V1 and V2 when you have an inferior STEMI. And if you have ST segment depression in those, then that should lead you to do a 15 lead ECG. And that's a lot of stuff to remember, isn't it? Like, yeah, maybe a little bit overwhelming. We will talk about more about this tomorrow. But here is a patient. Oops, sorry. Here is a patient that has ST elevation in 2, none in 3, but yes in AVF. So 2 or more contiguous leads. So they have an inferior STEMI. I look at V1 and V2 and even V3, and I have ST segment depression. So this person went on to have a 15 lead ECG, and they've just labeled them 7, 8, and 9. And you can see the ST elevation in these posterior leads. So this guy has an inferior posterior, and they might even want to do a right-sided ECG because patients who have RV infarctions require unique management, and we'll talk about that tomorrow. So I think that that is a good place to end today. So I can see that I have mildly bored you, kind of pushed you to like, oh my God, really? And so everybody learns in a different way. And so that's why I like to have your cameras on so that I can see that your brain is saturated. So there's no sense me just yapping at you. For the sake, I want you to learn. I want you to be able to apply. Tomorrow will be more interactive. We'll do some case studies. And so what are you going to do now before you go pick your kids up at daycare, before you start the crazy second job that you have of being the parent or being the spouse or being the person who just wants to have a life? What are you going to do?
Walk the dogs.
Absolutely. And see, 90%, I think statistically 67%, but 90% of people that have a dog get their activity, their number of steps in. And they don't think about their own health. It's, well, a dog's got to go for a walk. I'm going to show you a video one day called 23 and a half hours, and it's going to talk about why we really need to have 30 minutes of exercise. You can be fat and moderately fit. That's me. I like to go for a walk, but then I come in back and eat a bag of chips. So it negates it, but at least I went for a walk. So I want you to do anything tonight, nothing for homework. I want you to chill, enjoy your evening, and I will see you back here tomorrow morning at 8:30. Oh, John, can you hold him or her up? Oh, adorable. Hi. What's happening? Oh, there you go. There's a cute smile. Thank you for sharing her. Appreciate that. All right. Have a good evening, and I will see you all tomorrow morning.
Thank you, Sue.
You're welcome. Have a good evening.